22nd Kuwait Dental Conference. It's with a great pleasure to introduce to you Dr. Ekim Orhan. Dr. Orhan received his DS degree from Hacettepe University in Turkey in 2005. Then he achieved his PhD degree from the Health Institute, Science Institute at Süleyman Demirel University in Turkey in 2011. Dr. Orhan currently an associate professor and the head of the endodontic department at Eski Şehir Osman Gazi University. Dr. Orhan has more than 50 publications with the interest of endodontic instruments and dental material, including bioceramic. Dr. Orhan has lectured in many countries worldwide, where he received the Best Presentation Award in 2014, as well as the Scientific Incentive Award in 2022. Please just all welcome Dr. Orhan.
Thank you. Thank you. Dear distinguished guests, welcome to the presentation. I'm really excited to be here together with a great and amazing organization. Today I'm going to talk about retreatment, reciprocation, curved canals, and in a nutshell, tips and tricks for clinical application. This is my educational CV. I'm coming from there. I have practiced research and teaching for over 20 years. Now I am here with the sponsorship of the VDW company. I work with them since 2014. I have to disclosure the statement. I'm the key opinion leader of BioMTA Ceramics from Seoul, Korea. Today, we have to talk minimalism for gutta percha removal. It's a really complicated issue, and some practitioners ask frequently this question: how can you remove the gutta percha points from the canal? Today, we're going to talk about easy and efficient method. We also talk about some clinical tips. Let's begin. The aim of the retreatment is, let's remember from our essential endodontic lectures, to relieve symptoms and reestablish healthy periapical tissues following the failure of initial therapy, of root canal therapy. How we can do that? What's the success correlation? The success is correlated with removing filling materials from the canal. The success is correlated with ideally disinfected canal again. The success is correlated with addressing deficiencies of pathological or iatrogenical origin. There is a study, a recent study on a survey on the Swedish dental practitioners. They ask why root canal treatment is discouraging, why it is so complex for you. And general practitioner give an answer in a three-way. They said the root canal anatomy is complex. They said root canal treatment materials are too many and complex. They said we are working in the dark. It's a good definition for a practitioner. They are working without visible things. Where we are at the root canal, in dark place, a non-visible place. We can see our fillings, our restorations, but we cannot see a root canal treatment when we are doing that. Okay, let's share first some cases of mine, just showing working in the dark process of I did. This is root canal anatomy, little curved. We do this. We face all this every day. I know it's a piece of cake for you because it's just single curve, yeah? We have also some root canal anatomy with apical ramifications. Thanks for the technological improvement, give us the heat compaction techniques, heat obturation techniques. Yeah, I did. I did with this technology. In this case, I would like to focus on extraoral sinus tract. It can be happen. We cannot control the infection. We cannot control the type of bacteria. And sometimes we face off extraoral sinus tract. And what we can do? We should do cleaning, disinfecting the root canal, and obturation as much as we did before. Then healing is occur normally. But here, maybe you can see there is a scar tissue, are always seen that kind of infection, always. It is not healed totally with a little scar tissue every time stent. Extra root canals. Extra root canals are the sign of complexity of the root canal treatment. There is an orthopentagram. Orthopentagrams are not so reliable imaging. I ask my students, I ask my postgraduates all the time, which teeth is most bad condition, at most bad condition? They said this 6. But actually, in the primary root canal treatment of the number 7, they made some perforation, and that's happened. We have to extract it. I treated 6, 46, and number 36. Yeah, there are CPCT scans. There are triple root canal inside the tooth. Yeah. What about patients with that high risk group? Sometimes our cases are not so easy. Sometimes our patients are not so easy. This is a patient with chemotherapy history, radiotherapy history, surgery history of maxillectomy. Here, we cannot use rubber dam because the airway obstruction we faced, and he used a specific obturation apparatus. So I have to believe technological instrument. I have to believe my precise apex locator because I cannot take any intraoperative radiograph during the treatment. Yeah, it's ordinary root canal treatment. I believe you are doing better than me. This is a root canal. This is an anatomy. This is an open apex. This is also anatomy, but it is so complex. Complexier than the curved anatomy. So we have to do this. This is an instrument sized 140 ISO. The root canal, I think, have more than 2 millimeters opening. So I need to fill it in a material that is compatible for that kind of anatomy. I filled with bioceramics here. Yeah, it's normally extruded, but sometimes it's resolved. The extruded part is resolved. There is no surgery. It's not happen always, but sometimes the character of inflammation resulted this extruded part. I took the pictures with my phone on the screen. There is a healing. This is also an orthopentagram. It's not reliable method for following patients, but I would like to show, please don't make a decision-making extraction that big apical lesion with teeth, just given a chance to the teeth. Hippocrates says healing a matter of time, but also sometimes a matter of giving opportunity. Give opportunity for teeth. What about retreatment? Yeah, these are my cases. So easy, right? Root canal retreatment in this kind of obturated teeth are so easy. A piece of cake, 1 second with filling material, obturation material also come with that together. What about unwilling patient? These are nominated for retreatment. Let's check it out. Case 1 could be retreated, right? Case 2 could be retreated. Case 3 could also be retreated. There is no periapical lesion. Case 4 could be retreated. There is no cracks, nothing. But patients, they need to do the treatment. So first 3 cases, they decide to extraction. They decide. Decision makers are there. Case 4 only accept the root canal retreatment. I removed the gutta percha in 1 second. Then I filled and I made a little bit surgery. Yeah, it's healed. What about hopeless teeth? Even the patient who wants to do therapy, some teeth are hopeless. We cannot have any success with that. Perforation, resorptions, apical fracture, vertical fractures, this is hopeless. Okay. Let's talk about retreatment. Sorry, I go back here. This is really easy. You should not be any afraid for treating this. This anatomy is also not so important for extraoral sinus tract. Do the same thing. Clean the canal, disinfect the canal, obturate the canal, and wait. You see the scar tissue is over there. And this is coming from distal and another one coming from the mesial root canals. This is my table. There is some antibiotics inside on the table. And that antibiotics prescribed by the same patient in 6 months. You know why? Because he suffered from pain after root canal treatment, initial treatment. Let's look at the case. This case. He had suffered from some pain and tenderness, number 16, number 17, and number 27. Unfortunately, we have to pull out number 26. Yeah. After we finish the retreatment, he doesn't need any antibiotics. Please don't prescribe the antibiotics to people. Do retreatment. Do ideally disinfection root canal and obturated root canal. This is also a retreatment case. Seems okay. There is a lesion, and the patient wants to something to do this. They need to treatment. When I open, I found 5 root canals over there. Okay, and fill it. It's not visible for 5 root canals at the end, but now it's okay. Non-surgical retreatment. One more case. There are too many apical lesions on the pentagram. There are defects on the cortical bones, as we see in the CPCT scans. Then we treat it, and there is no lesion. This case was 20 years ago. A practitioner initially tried to place calcium hydroxide paste to the patient's lateral tooth. As you see, here there is a bulk of the material. Here, and the teeth with operated initially. What about patient? She had a infraorbitary inflammation. It looked like a trauma, right? Just because of that, the material intake. And we did standard root canal treatment. Just that. What about fractured instrument? This is a case presentation of lentillar spiral. It's easy to remove. I believe everybody here can easily remove this instrument from here. And then, after bypassing or removing the broken instrument, now it's time to making root canal treatment. But there are many complicated fracture situations we faced on every day. So what we can do? Yeah, this is my last publication in American Endodontists, Association of Endodontics. What we can do in each clinical scenario. We faced on apical fractures, coronal side fractures, beyond the apex fractures, and something. If you can scan the square code, you can freely download this algorithm here. It is really take time for understanding, explaining, but you can follow. It's easily find your way. This algorithm based on current literature. Our research team made this algorithm, and the relevant literature based on the inputs inside. So we can know objectively what we are doing regarding the current literature. What literature says there is. One more publication of mine. Let's see some example. We faced off some kind of anatomy like that. This is a retreatment case and also implant case. Yeah. He made an implant. I began to retreatment. Then there is one more root canal. The incidence of the anatomical branching is 5% regarding our population, in Turkish populations. I don't know the current status of the Kuwait, but 5% we faced off this situation, unfortunately. It's really hard. And let's continue the premolar anatomy. This is one more publication of us. These are the shapes of mandibular premolars. And this is the count of the apical constructions of mandibular premolars. More than one, right? We should do something for that. This is an hemisection cases. This is also retreatment. I made a retreatment and hemisection was done. This is extracted part. Yeah. We removed the old filling and made a little denture. And sorry, I'm come back here. Yes. This is the final status of the restoration before cementation. He has got 4 premolars right now. This is one of my cases. We published this. You can scan and download if you want. This affects the health status of the patient. This is Aspergillus sinusitis. This is caused by extruded material from the root canal to the sinus. If the root canal material consists of the zinc oxide, then fungi, Aspergillus, could be grown. And the health status getting bad. getting bad. The breathing obstructions can beginning at the first phase. It can be died with the aspergillosis. It's not less rate. What's happening? There is something error. I cannot mirroring right now. Sorry, I have to restart. Sorry. There is something wrong with the machine. Yeah, I turn. Sorry for the technical problem. I should restart it. Come here, please. Oh, thanks, God. Sorry for the delay. This is the particle we removed with the surgery. This is an aspergillus infection residues from the sinus. And we made tests. We analyzed the microbiota. Now, after standard root canal treatment, everything visibly resolved. We should not extrude it zinc oxide based root canal sealer. After all, we can cause a very harm situation for our patients. This is an interesting case of mine, and we see the hypercementosis like apices here. After the treatment, after the follow-ups, we found healing properly here. Then we understand there is calcific-like deposits of apical lesions. Now it's thinner. What about cracks? There is a crack of premolar. This is not suitable for retreatment. We extract it. We saw the crack line. Then we fix it with MTA and intentionally replant it. This is the last situation and the radiographical status of the current one. Let's talk about one more intentional replantation case of mine. Mandibular second premolar, no, molar teeth, sorry. There was a C-type anatomy. We extracted. This is a periapical lesion. We cut the apex. There is C-type root canal. As we can see, the cast post tip here, root canal C-type. We made a retrograde filling with fast-setting bioceramics. Within the 180 seconds, it's about 3 minutes. Then we put inside the socket here. Until the lunch break, I would like to explain the procedure of retreatment with a simple technique. I would like to tell one more thing before treatment plan. If you scan the code, you can download freely. We also use this algorithm for each cases to decision making. Okay. X-rays or CBCT scans are very useful tools for estimating curvature degree. We are talking about retreatment in curved canals in a simple method. So we need to know estimated working length and curvature degree. That was double curvature. This one is single curvature. No rubber dam, no endo. We should use isolating standards. And this is important. Now we're talking about this one for durability, ultra-conservative cavity, conservative endodontic cavity. But if we are doing retreatment, traditional access cavity is important. Making traditional access cavity preparation, please, to see what's happening there. Yeah, this is traditional access cavities. One more clinical tip, remove the all coronal restoration during the retreatment. Remove all one, not a partially. Remove everything, then see what's happening over there. This is one of my cases. I made partial selective retreatment. Here. I removed only mesiobuccal and mesiolingual root canals from the system because I see the leakage from here affected this apex and caused by apical inflammation, so I have to remove it mesially first for conservative weight, distal stent, and now the apical healing is seen. This is also selective retreatment case. Interestingly, this is a lateral tooth, upper lateral incisors. Yeah, it's weird, I know, but this is coincidentally comes to me with one root canal treatment initially. I did not touch the older one. I found a new one, and I found a missing canal. Then I treated easily. Cavity disinfection is recommended for all kinds of retreatment cases. Hypochlorite, it's a good selection. And visibility, use magnifiers use microscopes, use loops to observe floor of the cavity. Are there any missing canal? Are there any cracks, something, foreign body or posts? Then gutta-percha removal from the coronal third is important. Before using any other system, bulk of the gutta-percha from the coronal third should be removed by a rotary instrument as much as GG drills or heated pluggers. But heated pluggers are reliable when the root canal is curved, when the root canal is thin. Unnecessary preparation is not needed at this kind of curved anatomy or teeth. Yeah. And we are talking about today a simple method. The simple method is called reciprocation, one file endo concept. Yesterday we held on some course with about 12 doctors. Today I'm going to explain single file concept with retreatment. So we need the original motor sources. Ideally we should use the original motor sources when we are doing the retreatment, when we are doing the instruments. The instrument design forward and back motion, which is called reciprocating rotation. There is set values inside the machine, preparedly loaded machine. You don't have to change the settings. So we can remove the gutta-percha from the root canals easily. How we can do that? We let the instrument slowly advance in the gutta-percha with a light pressure, very light pressure, and move the instrument in and out motion with a light pressure. Just one instrument is sufficient for removing all gutta-percha from the root canal. We use successive packs, and the limit of the successive packs are 3. After 3, we remove the instrument, clean the debris, irrigate the canal, and do it again. We can continue this way until working length has been reached. Just that. Move the instrument with a packing motion. After 3 packs, remove the instrument, clean the debris from the instrument, irrigate the canal, and do it again until working length has been reached. There is one clinical tip. If the canal is so straight, the increments of the packing motion is not exceed 3 millimeters. But if it's curved canal, and we are at the curved region, the successive packs, amplitude of the successive packs reduced to 1 millimeter. Let's find the error here in the video from YouTube. There is something wrong. The practitioner tried to retrace this teeth model or extracted teeth with stationary. It is not making any back and forth motion, in and out motion. There is no insertion, there is no withdrawing. They're just stationary. But this video is not so work right now. I'm going to try this again. Yeah. In my computer there is nothing wrong, but on the screen there is a little bit blocking something. This is a wrong technique. The true technique is always keeping moving. If resistance encountered with an instrument, don't push it. Remove the instrument, and in this case, use the solvents. Use the solvents. You can use the gutta-percha solvents for 5 minutes maximum. 5 minutes maximum. Again, 5 minutes maximum. I have a story. One practitioner asked me, how we can do, how do we use that gutta percha solvents? Because he tried once, the patient suffered from a very big swelling and pain, tenderness, due to he used as a medicament for weeks. And after that, of course, normally it's resolved and extruded from the apex. Always we keep 5 minutes inside the root canal, then wash it and try to remove it with mechanical techniques. Chemical techniques always have risks. And please don't use at the apical region to solvents. This is the clinical tips. And I prepare a chart for you. What kind of gutta percha solvent is reliable? What I recommended for you. As you see, alcohol, eucalyptus oil, delimonen are safely using materials. However, even now, chloroform, turpentine oil are using, but they are so toxic. Toxic for dental tissues. And terrible smelling. This is my cases. You look what I'm doing there. Extruded gutta percha from the canal. Please do not use, when you are doing this technique, doing the reciprocation for removing gutta percha from the root canal, please don't try to use hand file to making glide path inside the gutta percha. You can do this. You can cause this as me. I am very complicated man. I do many complications all my life, and I try to solve how can I do the better and better and better. This is my failure. This is the same case. It was filled like that with apical lesion, as you see, and partially removed gutta percha and tried to create a glide path for removing safely. But yeah, here I extruded this. Then I filled with bioceramics, at least. What's happening? This is CBCT scan of the case. There is apical healing around the bioceramics. I know this is a borderline case. It is not regular things, but I have to do some conservative way for dissolving this problem. Yeah. How can I say? Changing horse in the midstream. Yeah. If you use the reciprocating technique for retreatment, don't change your horse at the midstream. After reaching working length, we should finally irrigate the canal, and lateral brushing motion is really good thing for removing residual gutta percha or sealer from the lateral walls of the canal. Then we can check the apical patency. We need to check apical patency after the gutta percha removal with ISO size 8 or ISO size 10. There is one clinical tip. There are some instruments designed by some complicated area of the canal, for example, MCK files or MCH files, to touching this area. These are my studies. Here we cannot touch with instrument, with any instrument. We can touch with that kind of special instrument in the complicated cross-sectional anatomy. To increase apical enlargement as necessary, depending on the treatment plan, use the larger instrument. I recommended at least 40 in infected cases with apical lesions. As we know that if the number of microorganisms exceeds the threshold level, becomes apical periodontitis. If we properly disinfect it, the apical healing can occur automatically. It's normal. Yeah, that's we are. We are human, we are alive, so we need to healing, okay? But if we cannot disinfect the root canal properly, microorganisms cannot be below the threshold level, so there is no healing. If we properly disinfect the root canal, then the tooth and apical periodontitis are healed. We need to reach optimally working with. That's why I recommended minimum 4006 for retreatment. So reciprocating instruments also offers 4006, which is called R40. If you want, you can make a larger one, R50, 5005. Yeah, this is my case. This is my video from a study. This study is the second one, but I published 3 of them. This is a meat, the size as much as a pulp tissue. This is a red meat from the cow. This is hypochlorite. Active chlorine content is 525. And let's see what's happening. We need to use hypochlorite solution for ideal disinfection to remove organic debris. After 1 minute, it's getting its weight and swim. You can find and download freely this video from the publish. As you see, doctor do nothing. Doctor do nothing. Just hypochlorite works. And EDTA, we need chelators for disinfection, ideally cleaning. Of course, chelators are not disinfectors, but it's help to create a cleaning canal, help to assist to disinfection. And please use at least 15% of chelators, 15% chelators. In Turkey, there are many different materials available in dental markets, especially 5% of EDTA. But regarding the time, 17% or higher is better. And this has led to good sealing. If we clean properly, we can seal properly. This is one of my study, the pictures of mine. Yeah, the red, yellow parts, we can see how sealer material penetrate into the tubules. And let's take a look at matching needle size and ISO size. If we use side perforated 30-31 gauge needles, this is okay. It's matched corresponding to ISO size 30-35. But if we use dental syringe and dental needles with open apex, so it's matched with 45 size ISO. So we should enlarge more and more. First one is okay. First 3 are okay. And it's recommended for studies. And without brushed needles and side perforated needles are recommended. What about the placement of the needle tip? If we used open needle tip, our needle tip is placed at minimum 2 millimeters away from the working length. If we used side perforated needle, we should place it 1 millimeter away from the working length. And pressure is dangerous when we irrigate this. We can use perfusors. Your dental assistant used this for irrigation. Ideally, 0.2 milliliter per second is recommended by literature. If we deliver the irrigant so fast, there is some problem occur, vapor locks. And we cannot remove it from the root canal. This is the cases of my student. This is a vapor lock effect I'm going to show you. There is a working length with master file. There is a cone checking, master cone checking. There is nothing problematic here. You see, he was hurry up for disinfection, and persistent vapor lock has happened. And please keep in mind to aspiration from the canal to any kind of disinfected solution. One more thing, we need to activate our solution in a better way. The sonical agitation is recommended for many, many cases, and it's sufficient and cheap one according to the rest of the system. It is more efficient than the regular irrigation. And please remind, do not mix two types of different irrigants into the canal. They are interact. We can use this kind of sonical agitation instruments for using root canal sealer placement, and we can remove it. We can clean. Okay.
The transfer question.
Okay. And hurry up. This is last one. And we can disinfect the cones with 1% to 5% hypochlorite solutions. The last one I would like to show you, please use bioceramics today. We know the favorable outcomes of bioceramics right now. This is one of my cases, experiments filled with bioceramics. There is a natural sealing with hydroxyapatite from the apex here. Today I told technique just designed for most cases, but it is not useful for 100% of cases. This is more than 80%. We can safely use this technique that I explained today, but variations are always happen. Good instrument works, good solutions. That was 20 years ago. I had just this kind of instruments, CC cords, VDW. Now I have good instruments to making good solutions. Yeah. Thank you for listening. Do you have any questions, by the way?
Thank you, Dr. Orhan, for your very informative lecture. Anyone has a question, please? Just raise your hand.
Thank you, Doctor. Doctor, you mentioned that we shouldn't mix irrigant solution in these cases, but if I want to use 17% EDTA and sodium hypochlorite irrigation, should I use them
Together?
Together, yeah. Or should there be any irrigant in between?
Can you see the second one? Literature. This is the recent literature of mine. I'm really interested in the irrigation interactions. I have chemists in my research team. So I published the molecular interaction of ethylenediamine tetraacetic acid after mixing sodium hypochlorite. The second one maybe you can see there. This is also interact together. If you when you perform the final disinfection, use hypochlorite, okay, 10 milliliter, for example, per each canal, then dilute it with sterile saline solution, sterile distilled water. We purchased from the medical suppliers, and then we should use EDTA because they interact. Hypochlorite interacts with EDTA. It affects to chelating ability.
Okay, thank you.
Thank you
so
for this. This is a very good question. Thank you.
Actually, I have two questions.
Thank you.
First, about the bioceramics. Okay.
Sorry?
About the bioceramics.
Bioceramics,
Yeah.
thank you.
Do you think we have enough outcoming studies to confirm the efficiency of the use of these kind of sealers, not only in vitro studies?
Okay. Can I answer? Okay. Bioceramics, today's technology, but it needs to improving because the adhesion quality is less than resin-based one. Adhesion is important for clinical performance, I know, and the setting time is so long in the bioceramics. This is the disadvantages. But on the other side, we are putting something natural inside the canal. Therefore, all endodontic researcher and manufacturer look at that side. Even it has got drawbacks, the benefits are so valuable because they are so natural. Yes, I understand you, and we need time for understanding this kind of material, and we need to wait to improving this kind of material in an adhesion way and in a setting time optimization.
Okay,
Thank you, Dr. Orhan.
The second one.
We are running in tight schedule, so any question maybe after, I think Dr. Orhan will be happy to answer. Thank you very much. Again, I would like to thank you for
Thank
your
you.
informative lecture. Please all welcome Dr. Orhan one more time.
Thank you.
طيب خلينا. اوكي ايوه ان شاء الله.
يمكن تحطها داخل
خليه جوا. تعال زولت ما تمام.
Sure.
Yeah. تمام.
Good afternoon, everybody. If I could have your attention, please. I'm very honored to introduce Dr. Abdulaziz Bakhsh.
My pleasure. Thank you.
He received his bachelor degree in dental medicine and surgery in 2012.
12.
Finished his master's of clinical dentistry in endodontology in 2018. He's a fellow of the Royal College of Surgeons of Edinburgh in 2018 as well. He received his clinical PhD in microbiology and immunology in endodontics in 2022, and he is currently an assistant professor in Department of Restorative Dentistry in Al Qura University, Faculty of Dentistry. Please welcome Dr. Abdulaziz.
Thank you. Thank you very much, Doctor, for your kind presentation. Thank you, everyone, for attending today. So I'll be talking about the association between endodontic diseases, its treatment, and systemic health. Just let me take this opportunity to thank all the organizing committees and organizers for such a successful event, and for the great hospitality. Before I start, I would just like to give a brief overview about where I came from. So I'm originally from Jeddah, however, in Saudi Arabia. However, I grew up and studied in Egypt, where I had my bachelor degree in Misr University for Science and Technology. I've met a lot of friends from Kuwait there, and actually I had they're more than a family to me here, and most of them are here in the audience as well. And there are some pictures of friends, and this was just yesterday, and people living here as well in Kuwait. After finishing my undergrad, I went back to Saudi, where I had my internship here, and then I was appointed as a teaching assistant in Al Qura University. Then I had the opportunity to go to King's College, where I had my MClindent and the membership of the Royal College, and as well my Kuwaiti family grew larger and larger, met a lot of good endodontists from there. This is where we used to work. I don't know, the pointer is not really working well, but just above the black thing on the building there. So some of them are here in the audience, and some of them are, I don't know if they're all here. Then currently I'm back to Mecca in Al Qura University, Faculty of Dentistry, and this is where I currently teach undergrads and postgrads. So the outline of the lecture today, we'll be talking about the etiology of apical periodontitis. We'll give a brief overview of the focal infection theory. We'll talk a bit about bacteremia, and we'll learn about endodontic diseases and systemic impact. And then we'll briefly talk about cardiovascular diseases and the formation of atherosclerosis and the effect of inflammatory markers. And then I'll show you what we've done in the clinical study that we've taken at King's, and then we'll briefly talk about apical periodontitis and systemic health. So first, what is the etiology of apical periodontitis? So apical periodontitis can occur as a result of dental caries, dental trauma, defective restoration, or exposed dentine. If the caries was left untreated, it will reach to the pulp where it becomes inflamed, and then it might get necrotic, and an apical periodontitis will be formed. So why is it important? Why I'm talking about the effect of apical periodontitis on systemic health? In this study, they looked at the global prevalence of apical periodontitis, a systematic review and meta-analysis, and it is causing a global burden, as it has been found that 52% of the global population actually have apical periodontitis. A few days ago, we've reached 8 billion, I think, people in the worldwide. So we're talking about 4 billion person is actually having apical periodontitis. When we're looking at tooth level, 5% of the patients have apical periodontitis, and in root-treated teeth, 39% of them had apical periodontitis. Most importantly, patients with systemic conditions, 63% of them had apical periodontitis. So this gives an idea of how an effect of apical periodontitis and systemic health can cause a correlation or an interaction between each other. So, what is the systemic effect of endodontic diseases? Let's try and make it simple because the inflammatory markers are, like the immunology part of it is a bit complicated to most of us. So the human body has some guards, or I would say some guards, like a defensive mechanism or defensive mechanism of the body. So when bacterial toxins enter the body, you get two different lines, or like you have the innate response and the the adaptive response. So the innate immune response is the first line of defense, where you first have the inflammation. They're the first guards that go and try and fight this microbiome, or like the bacterial toxins and the microorganisms. When either the innate or adaptive immune response gets activated, they secrete some inflammatory markers. So they are the interleukin 1, interleukin 6, 8, and interleukin 7, and some chemokines and macrophages. And they also secrete the antigen-presenting cells, and T cells and B cells. When these markers are extracted or are upregulated in the body, they stimulate the rank and the pre-osteoclast cells to form rancal cells and osteoclast, which then causes bone resorption and what we see in the radiograph as an apical periodontitis, along with other inflammatory markers or matrix metalloproteases like MMPs, MMP2, MMP8, and MMP9. So, again, why is it important? Okay? That's what we're going to know in this lecture. So, why did people look into that? So, that's the focal infection theory. That's what happens. Previously, this focal infection theory, people started looking at it, and it started a long way ago. So what is the focal infection theory? The focal infection theory, it is a localized or a generalized infection, often asymptomatic, and it causes diseases somewhere else in the human body. What is the history of the focal infection theory? First, it started with Miller in 1890, when he mentioned that oral microorganisms and their byproducts spread to different body parts. However, his claims were not based on any scientific evidence. It was only on unreliable opinions and few case reports. After Miller came William Hunter in 1900. He said that poor oral health was the cause of meningitis, nephritis, gastritis, osteomyelitis, ulcerative endocarditis, and nervous diseases. Again, his claims were also based on case reports. Then in 1925, Weston Price came and said that the toxins and bacterial components gets entrapped into the dentinal tubules and act as an antigen. This antigen travels to different body parts, causing different diseases, and he recommended tooth extraction. However, Eastlick in 1952, I couldn't find a picture of him, so I just put the paper that he mentioned. He said he pointed a lot of flaws in Price's methodology, and he disproved the association between endodontically treated teeth and systemic diseases. After that, the focal infection theory just went to bed. No one was really talking about it. So, is it true? Is it a myth or is it a fact? We don't know. What we know is that there are some changes that occurs in the human body if there is an endodontic infection. And it all came back to attention when the Perio guys did this study, when they looked at the association between periodontal diseases and systemic health. They looked into 74 participants, and they found that there is an independent association between periodontitis with atherosclerotic cardiovascular diseases. And most recently, in 2013, a consensus report based on 4 papers in a joint workshop done by the European Federation of Periodontology and the American Academy of Periodontology, they concluded that there was a strong and consistent epidemiological evidence that periodontitis results in an increased risk for future atherosclerotic cardiovascular diseases. So why are we linking this to endodontics? Because periodontics and endodontic diseases, both, they have different pathogenicity, however, they're common in different things. So they both are chronic infections. Both of them share the same pathogens and the same inflammatory mediators, and they both have the same biological pathways. Also, both of them increase the risk of bacteremia following treatment. So what happens when there is a chronic apical periodontitis? First, we have the circulating acute phase proteins, or the C-reactive proteins, and cytokines get secreted with other matrix metalloproteases and soluble adhesion molecules. Then we have the soluble microbial compounds of the bacteria, which is the lipopolysaccharides and peptoglycans, and also bacteremia occurs. When these 3 happens, then it goes to systemic circulation, and they stimulate the innate and adaptive immune responses. After that, they cause a chronic low-grade systemic inflammation, which causes an increase in the levels of inflammatory markers, and then they cause an adverse effect on the target organs, and this leads to systemic diseases like cardiovascular diseases, diabetes, and etc., like cholesterol levels as well. So let's talk a bit about bacteremia. Since 1977, Bob Martyr was looking at the bacteremia in different dental treatments. So he found that after non-surgical root canal treatment, 3.3% of the cases had bacteremia, and 33% with periapical curettage. Then Himedal in 1990, using also culture-based techniques, he found that 20% of the cases with root canals had bacteremia. Then Debilian from 1992 until 1998 was also really interested in such topic of bacteremia with root canal treatments. So first he looked at the types of bacteria that was recovered from blood in cases where over-instrumentation was occurred. So he found that P. acnes was one of the species that was found in blood in cases where over-instrumentation was there. Then, in 1995, he also looked at, again, with different groups where over-instrumentation occurred and where instrumentation was confined within the canals. So when over-instrumentation occurred, he found P. acnes, Fusobacterium nucleatum, and Prevotella intermedia. However, when the preparation was inside the canals, he found Prevotella intermedia, Actinomyces israeli, and Streptococcus intermedius, and Streptococcus sandius. In 1996, he confirmed the findings of the 1995 study, and in 1997, he also confirmed the findings of the other studies. However, in 1998, he finally gave us a percentage of the bacteremia occurring of bacteremia after root canal treatment, and it was 31 to 54% of the cases. Then Savario in 2005, he looked again in bacteremia using culture-based, and he found it in 30% of the cases. And lastly, Rees in 2016. He was the only one using the molecular approach, the qPCR, and he detected bacteremia after non-surgical root canal therapy in all of the cases where bacteremia were not found in culture-based methods. This is because in culture-based methods, not all of the microbiomes are actually culturable. So, again, before we look into the connections between apical periodontitis and cardiovascular disease, what happens with bacteremia? Bacteremia, when it occurs in the human body, it goes and it seeds into different target organs, and then it causes the chronic low-grade systemic inflammation, adverse effect on target organs, and then the systemic disorders, like cardiovascular diseases. So let's talk a little bit about cardiovascular disease, like just to quickly go through cardiovascular diseases and what really occurs and the connections between it and the apical periodontitis. So cardiovascular disease, it's just the umbrella term for the conditions affecting the heart and the blood vessels. It is responsible for 30% of the total global mortality. The most common cause or the most common type of cardiovascular disease is coronary heart disease, and it compromises 49% of the total cardiovascular diseases worldwide. So what are the risks of cardiovascular disease? We have the high blood pressure, the high LDL cholesterol levels, diabetes, and obesity. All four together form a term called metabolic syndrome factors. Also, smoking is one of the risk factors of cardiovascular disease, unhealthy diet, and physical inactivity. So, what is the pathogenesis of coronary heart disease? The pathogenesis of coronary heart disease is the formation of atherosclerosis, which is an inflammatory process that involves the formation of a plaque affecting the layers of the large and medium arteries, including the coronary artery. These plaques are accumulated of lipids and connective tissue along with inflammatory endothelial and smooth muscle cells. So in the initial lesion, you get an endothelial dysfunction and increased endothelial permeability, and then you get a migration of LDL and the formation of oxidized LDL, and then monocytes infiltration and differentiation into macrophages, which takes up the oxidized LDL and form foam cells. These foam cells precipitate into the vessel walls, causes an upregulation. They precipitate into vessel walls and causes upregulation of VCAM, ICAM, and E-selectin inflammatory markers, and it adhere and transmigrate to monocytes and T cells. And it causes an upregulation of TNF-alpha, interleukin-1 beta, and pentraxin-3 and interleukin-6. Then they cause an athereoma, which is an accumulation of lipids, and then also macrophages, mast cells, and T cells. After that, they cause a fibrous plaque and cause the fibrotic and calcific layers, and then we get the complicated lesion. And after we get the complicated lesion, we have macrophages, MMPs, and cause an impaired endothelial cell release of E-selectin, pentraxin-3, and TNF-alpha. And macrophages also produces the pentraxin-3, TNF-alpha, and interleukin-6, resulting in plaque rupture, and then thrombosis and blockage of the vessel occurs. So, studies have looked into whether endodontic lesion is actually a risk factor for coronary heart disease. One of the studies, a review article, looked whether the lesions of endodontic origin, is it an emerging risk for coronary heart disease? And they concluded that there was a possible correlation between coronary heart disease and apical periodontitis at microbiological, clinical, and inflammatory and molecular levels. Another study, in a systematic review and meta-analysis, they looked at whether apical periodontitis is associated with an elevated levels of inflammatory markers, the ones that we looked into, like C-reactive protein, interleukin-1 beta, pentraxin-3, VCAM, and ICAM. So they've concluded that the existing literature indicates that apical periodontitis, it adds on to the systemic inflammation by elevating the levels of C-reactive protein, interleukin-6, asymmetric dimethylagrenine, which is called ADMA, and then C3 levels. And they suggested that more prospective and longitudinal studies are required. Then, most recently, this umbrella review looked at the association between cardiovascular diseases and apical periodontitis, and they highlighted the need as well for future well-designed longitudinal clinical studies to strengthen the evidence to confirm a potential association, because they found that the evidence is weak on the association between apical periodontitis and cardiovascular diseases. And this is where our study came. You can download the study and look into it. We looked at the impact of apical periodontitis, non-surgical root canal treatment, and periapical surgery on serum inflammatory markers. The methodology of our study was, we included patients more than 18 years old, patients requiring non-surgical root canal treatment, and patients requiring periapical surgery. We excluded smokers, pregnant women, patients with chronic inflammatory conditions, patients on medications altering the bone metabolism, and unrestorable teeth, patients who had antibiotics 3 months before the examination and the treatment, and patients who had surgical procedures 6 months before we start the procedure. So during the consultation appointment, we took a consent from the patients, we measured their height, weight, and waist circumference, we did our intraoral examination, and we took a periapical radiograph and cone beam CT preoperatively, and we measured the blood pressure. Then, we recruited 115 participants in this study. 50 of them were healthy controls, and 65 patients had apical periodontitis. What did we do with those patients, the ones that had apical periodontitis? So before the treatment, we took saliva samples and blood samples in 2 tubes. One would be for serum and one would be whole blood. And then they underwent either non-surgical root canal retreatment or periapical surgery. And then from the blood, the whole blood samples that we take, we measured their HbA1c levels for diabetes, total cholesterol, HDL, LDL, and the total cholesterol over HDL. Then the saliva samples and blood samples were centrifuged, and we separated the serum from the blood, and we took the saliva supernatant. Then these samples were aliquoted into 0.5 ml samples, and then we froze them in the -80 freezers. Once we get 40 samples together, we started our sample processing. So the sample processing went through Luminex and ELISA. The Luminex, we tested FGF23, interleukin-1 beta, interleukin-6, interleukin-8, C-reactive protein, pentraxin-3, TNF-alpha, MMP2, MMP8, MMP9, E-selectin, VCAM, and ICAM. Sorry. And for the ELISA samples, we looked at C3 and ADMA. The results of our study, for the metabolic syndrome factors that we mentioned before, we found that patients with apical periodontitis had a significantly higher levels of HbA1c when compared to healthy controls. Also, we found that total cholesterol levels were higher, however, not statistically significant, and a higher LDL levels in the root canal retreatment patients than the controls patients, and the triglycerides levels as well were higher in patients who had apical periodontitis than patients that didn't have apical periodontitis. The BMI as well, it was higher in patients who had non-surgical root canal retreatment, and the waist circumference was larger in patients who had root canal retreatment. So the serum levels of inflammatory markers, we found that interleukin-1 beta, C-reactive protein, FGF23, and ADMA were statistically higher preoperatively in the apical periodontitis group than in the control group. Then, what happens after we treat those patients? We reviewed those patients for 3 months, 6 months, and 1 year. During the 3 and 6 months appointments, we took intraoral examination and blood samples again. And for the 1 year review appointment, we did intraoral examination, blood samples, we measured their HbA1c, total cholesterol, LDL, and HDL, and we took a periapical radiograph and cone beam CT again. 1 year post-treatment, our outcome was 76%, the recall rate was 76.9% during COVID time. So I consider this a success to get those number of patients during COVID time. So the outcome with PA and CBCT, if you look at the 1 year outcome, most of the cases were in the healing phase. So most of them, the lesions has reduced in size, however, it didn't heal completely. 11% with CBCT was failed, and 25% were completely healed after 1 year of treatment. So let's look at the serum levels of biomarkers. I won't go into details in this because it will be really boring to talk about all of that. However, here you can see that the C-reactive protein increased at 3 months, as this were at 3 months, this will be a pro-inflammatory phase. So what happens when we do the treatment is that the same inflammatory markers that were secreted, so they go into the reparative phase rather than the inflammatory phase. So it is the pro-inflammatory phase of the treatment. So during the first 3 months, the C-reactive protein, it is considered as an acute phase inflammatory marker. So it was increased after 3 months. I guess if we measured it at 7 days, it will be much, much higher than what we found in 3 months. So also, we looked at, if you look at interleukin-1 beta and C3, they all were upregulated during the 3 months because they were, again, in the pro-inflammatory phase. Okay. However, as the pro-inflammatory phase and remodeling takes place, it goes down, if you see, at the 6 months and 1 year. Now it is like the end of the reparative phase. So now other inflammatory markers takes place. So this were the acute phase. When we first finish the treatment, they start for the repair and remodeling. And then after that time, when bone healing occurs, then other inflammatory markers takes place and gets upregulated, and these markers start reducing. So what you want to notice is, if you look at the root canal retreatment and the apical surgery, they all had the same outline. So increased at 3 months and then decreased at 6 months and 1 year. Other inflammatory markers, these are the ones for, responsible for bone remodeling. If you look at those gelatinases, or like the matrix metalloprotease, MMP2 and MMP9, at 1 year, they are much higher than how they are in 6 months and 3 months. These are the ones that are responsible for bone repair and bone remodeling. As most of our cases were in the healing phase, so these markers were still in action. Again, if you look at retreatment and surgery, they both have the same effect. As well, these markers have had different responses, either by increasing or decreasing. However, FGF23 was the only one reducing from the pre-treatment until 1 year. And you can notice as well that root canal retreatment and periapical surgery had the same effect. Recently, we did a 2-year review done by our colleague there in King's College, Dr. Noor Al-Abdallah from Qatar. And what we found is that C-reactive protein, if you look here at 2 years, it massively reduced because the acute phase is finished, and now it's like we're already in the remodeling phase, or like finished the remodeling phase. So it has reduced even lower than the preoperative levels. The ADMA as well has reduced in numbers. MMP2s, because most of our samples now have healed, so they have reduced in numbers, and ICAM as well was slightly increased in both apical surgery and root canal retreatment. So the question would be, as FGF23 was the only inflammatory marker reducing from T0 up until 1 year, could it be an outcome predictor? So can we do the treatment and then maybe after 3 months take a blood sample, measure FGF23 and see if it's reducing? Is it an outcome predictor that this case will actually heal at the end? Or if it's increased, is it going to fail? So should we intervene earlier? That's a question that we can look into. Another question would be, as the inflammatory responses was similar between non-surgical root canal retreatment and apical surgery, should root canal retreatment be considered as invasive as periapical surgery, or should periapical surgery be considered as less invasive as root canal retreatment? That's an area that we still don't know, and we can look into that. So now let's look a little bit about what the literature has said about the relationship between endodontic diseases and systemic diseases. So when looking at the association between systemic diseases and apical periodontitis, this review suggests that there may be a moderate risk and correlation between some systemic diseases and endodontic pathosis. However, when looking more specifically in endodontics and diabetes, Segura-Iga found that these two variables are associated by having common risk factors, but without the existence of a cause and effect relationship. So what happens with the interaction between diabetes and apical periodontitis? First, obesity, physical inactivity, and nutrition and infection, they are a risk factor for diabetes mellitus. And then root canal infections and microorganisms with the metabolic byproducts and toxins, they are risk factors for periodontal diseases. The diabetes mellitus causes an effect of decreased tissue repair, increased the persistent chronic apical periodontitis, while apical periodontitis affects the diabetes mellitus by causing metabolic dyscontrol. So, diabetes mellitus causes a secretion of fatty acids, and the lipopolysaccharides from the microorganisms of the periapical periodontitis, they both cause an increase in the innate immune response and decrease in the growth factors by macrophages. This would cause this with the nuclear factor kappa and interleukin 1 beta, interleukin 6 and interleukin 8 cause a chronic systemic inflammatory state where they both cause an increase in the insulin resistance, increase in pancreatic beta cell apoptosis, and decrease in pancreatic beta cell apoptosis replication, which then will turn diabetes. So it's like a cycle. So the one would really affect the other one. Periapical periodontitis would affect diabetes, and diabetes would affect the outcome of periapical periodontitis. When looking at hypertension and dental periapical conditions, Segura-Iga again found that there is no significant association between hypertension and periapical diseases. So when looking at the prevalence of apical periodontitis in patients with autoimmune disorders, in this retrospective study, patients affected by autoimmune diseases like rheumatoid arthritis, psoriasis, and irritable bowel syndrome had a higher prevalence of apical periodontitis compared to healthy controls. And this may be due to the role of an excessive production of common inflammatory cytokines between apical periodontitis and the rheumatoid arthritis or the autoimmune diseases. So the invasive dental, in this study, Minisian looked at the invasive dental treatments and the risk of cardiovascular events. So he looked at 650 patients who had ischemic stroke and 525 patients with myocardial infarction. After having invasive dental treatment, 4 weeks after the treatment, they were 1.5 times more prone to having a vascular event. However, the absolute risk was minimal, and long-term benefits of vascular health will probably outweigh the short-lived adverse effect. And if you really want to know more about endodontic infections, its treatment, and systemic health, you can go to this paper for more information, and most of the things that I've mentioned in the lecture are actually mentioned here in this narrative review. And before I finish, you can finish the pictures. Before I finish, our take-home message would be, apical periodontitis increases the systemic inflammatory burden. Bacteremia is associated with apical periodontitis and endodontic treatment. And lastly, successful root canal treatment will cause a beneficial impact on the systemic levels of inflammatory markers. And lastly, this was my PhD supervisor, Dr. Sadia Niazi, and our father of endodontics at King's College, Professor Francesco Manucci. And this was Dr. Fadi Jarad, who examined me during my PhD, and Dr. David Daymok. Thank you very much for listening, and if you have any questions, please don't hesitate to contact me. Thank you. Thank you very much.
Thank you, Dr. Abdulaziz, for
Thank you.
your very interesting and informative lecture.
Thank you.
Anyone has any question?
يعطيك العافية
الله يعافيك
وشكرا
دكتور.
على المحاضرة.
الله
We always have this issue that have you seen Root Cause movie?
Root cause, yeah. I actually didn't finish it. I watched a bit of it, and up until the part where this lady was on crutches, and then she went to dental treatment, and immediately after the treatment, she was like, "Oh, I can walk now."
Yeah.
But I don't really believe on it.
So the issue is that every now and then it comes back, and we get these videos on WhatsApp and messages that we shouldn't do root canal treatments because of the whole focal infection theory. So my question is, so does it really cause diseases, apical periodontitis, or the diseases are there and it makes it worse? That's question number one. Question number two, is it microbial or is it mainly inflammatory? يعني
Okay.
باختصار.
Yeah. Okay. So for the first question regarding the, is it sorry. So okay, let me go to the second question because I really remember it. So microbial or inflammatory. So some of the microbes cause an increase in the inflammatory markers. There is a second part of this lecture which is totally microbial because there is a hidden part of this study where we actually took samples, intracanal samples, and glove samples, and as well we looked into bacteria in blood as well. And we correlated those with the levels of inflammatory markers. What we found are some of the microbes causes an increase in the levels of inflammatory markers. This increase of inflammatory markers actually increase the risk of having some cardiovascular events. This takes us to the first question, whether it is an actual cause. Will it cause a cardiovascular disease or not? I don't think it would. Let me simplify it in a way. If you have a laptop, for example, and part of it is not working, yeah, the whole laptop would still work, but it will be like with less efficiency. So that we all look at teeth as an isolated part. It is a localized infection rather than a systemic infection. However, the human body is like a one system, you know? So if you have an infection somewhere in the body, it would somehow affect the whole system. However, it won't be an actual cause of another disease. So it would increase the risk of having it, but not an actual cause of it. Does that answer the questions? Yeah. Thank you.
Any more questions?
يعطيك العافية دكتور.
الله يعافيك.
My question, just following Dr. Samhan's question. Since we now know that majority of it is it's inflammatory in nature rather than actual bacterial, do you actually recommend giving low doses of anti-inflammatory as precaution for every single patient, or autoimmune, or patients that are immunocompromised? My second question is, why are we placing so much emphasis on bacteremia caused by non-surgical root canal treatment or surgery, while in fact we know it's transient? While we know also for a fact that brushing our teeth, for example, is an actual cause, or just purely living our day-to-day life.
Yeah. So the bacteremia here. So I'll answer the second question then as well. Go to the first question again. So the bacteremia here, if you look at it before the treatment, so there is actually bacteremia caused by the apical periodontitis lesion itself in the human body. So it travels in the blood as well. Although it is transient, it can be seeded into different body organs and then causes an increase in the inflammatory response of the human body. So does this answer this question? Then the second question, or like the first question, is sorry if you if you repeat the first question.
Since we know it's inflammatory in nature rather than actual bacterial.
Mhm.
Most of it because increase in the inflammatory markers.
Yeah.
Do you actually recommend giving low doses
yeah,
of
the low
anti-inflammatory
Mhm.
for patients that are immunocompromised
Mhm.
or as a precaution or for every single patient that comes to your clinic?
So I don't really recommend giving anti-inflammatory drugs because what caused the inflammatory markers to increase is actually the bacteria that are present from the root canal. So if you remove the cause, like any other dental treatment, you remove the cause first, then this would cause an ease of the inflammatory markers, so they will go down eventually after you finish the treatment. So to answer your question, I don't think I recommend giving anti-inflammatory drugs pre-treatment. I can give it for pain reasons, and that's like a different lecture. But for just an inflammatory markers point of view, I don't think I would recommend. Thank you.
Any more questions? Thank you, Dr. Abdulaziz.
Thank you.
Again, once
Thank you
again, I
very
would like to
much.
thank you.
Thank you very much.
يعطيكم العافية. عندنا 15 minutes if you want to take a quick break. Okay.
Assalamu alaikum. I'm really glad today to present to you Dr. Samhan Al-Ajmi. Dr. Samhan Al-Ajmi, first of all, he's my mentor and my teacher. And Dr. Samhan, he's the Assistant Program Director of the Kuwait Board of Endodontics. He graduated in 2008 from the University of Dundee, and then he received the membership of Faculty of Dentistry from Royal College of Surgeons in Ireland in 2010, and he finished his endodontic residency from University of Pennsylvania in 2014, and also a fellowship in implant from Tufts University in 2015, and at the same year, he also was awarded the diplomate from the American Board of Endodontics. Dr. Samhan, the stage is yours.
السلام عليكم مساء الخير الجميع وحياكم الله. I'm very grateful that you're here in this beautiful weather outside. So really thank you for being here. And also I'd like to thank the KDA for this invitation to talk about one of the most important topics in the past couple of years, and that is vital pulp therapy. So today I'm going to give you good news that finally vital pulp therapy works in irreversible pulpitis. I'm going to show it to you today. And there has been a lot of research for decades to try to see if vital pulp therapy works, since the 70s or even before. So the change is slow but dramatic. So finally, we find the solution and how it works, and this is what we're going to talk about today. الفيتال pulp therapy من المواضيع اللي صار فيها tension in the past couple of years. لاحظنا فيينا، المؤتمر اللي بفيينا 2019 كان محور الحديث كله عن vital pulp therapy. Also Budapest قبل شهرين, for those who attended, لاحظوا ان موضوع الفيتال pulp therapy هو كان center of the conference. So really very interesting recent results that we got. My interest in vital pulp therapy started more than 10 years ago. This is my first presentation when I was doing my residency, and it was about vital pulp therapy. And من ذاك الوقت, every year I have to update my presentation based on what is published, and this is the version of 2022, a major change between my first presentation and today's presentation. I also talked about reversibility of pulpitis, and that was in 2012, where I challenge what kind of things that push the status of the pulp from reversible to irreversible, and what causes the irreversibility, and how can we tell if the pulp ever goes from reversible to irreversible. I also did another presentation on marginal leakage and vital teeth, and in this presentation what I talked about is that how vital teeth respond differently from root canal treated teeth when it comes to leakage. So really I had a good background من ذاك الوقت, and if I show you the historical perspective over the past 10 years, we have more than 40 outcome studies done in the last 10 years. That includes 3,500 teeth, with the average recall is 24 months, and the recall rate is 88%, so really something good. We also had the European Society of Endodontics position statement in 2019, and also we had the AAE position statement in 2021. And this was done, the AAE position statement was done purely online during the pandemic. So this is a good achievement. And also we had, in the past 10 years, 20 meta-analysis and review papers. So the data speaks for itself. And the change is coming, and in fact, it's already here. Whether you can choose to ignore all the evidence, or you can embrace it and start practicing. You can ignore it and resist, and eventually you will follow, or you can embrace it and lead in this field. So I feel sorry, Yani, when someone comes and says that vital pulp therapy doesn't work. We have 2 position statements from the largest endodontic societies in the world. They all agree on vital pulp therapy. So I think you should start considering it. And another issue is that sometimes when someone graduates from a specific program or a specific university, they develop this dogma, aqidah. It's hard to change. They resist to change. So I think we should learn how to be open to change. And whatever I learned in the university is completely different nowadays. And that is because you have to keep open to change. If we look at the definition of endodontics from the glossary of endodontics of the AAE, it's a branch of dentistry concerned about morphology, physiology, all the way to the etiology, diagnosis, prevention, and treatment. So prevention, the word, comes before the treatment. And you need to think about how much prevention do we do? Do we do a lot, or very often we jump into treatments instead of thinking about prevention? Prevention, mafhum, in medicine, everybody is using it. If you go to a cardiologist and you have high blood pressure, they might think about prevention. They might change your diet. They might recommend changing lifestyle. They don't jump into treatment now immediately. So it's the same for us. We should think about prevention. Now, the next question is, why do we care about vital pulps? And I want you to think about 2 terms: the restorative cycle, okay, or the tooth's career. It's the same. But this term, I took it from pediatric literature, which is interesting, tooth's career. Let me explain what do I mean by the restorative cycle. Now think about a graph, and in one axis you have the tooth integrity from 0 to 100, and the patient age. And the more restorative work, the tooth integrity with time decreases. Okay? So, why is this important? It's because success is temporary. It's a temporary phenomenon. The majority of studies, the majority of outcome studies, when they do them, it's either 1 year or 2 years follow-up, right? Some studies might have 5 years. Few studies have 10 years follow-up. But really, if you ask someone what is the success rate of any procedure, such as root canal treatment, after 30 or 40 years, nobody can answer this question. Nobody knows what is the success rate after 40 years. So, for that reason, success is a temporary phenomenon. And one of the things, the good thing about vital pulp therapy, it can prolong the tooth integrity by avoiding root canal treatments to maintain the integrity of the pulp, of the tooth structure, where you don't have to place a crown, things like that. One of the papers that looked at the long-term survival of endodontic at a specialist, and that is 10 years. 10 years is considered long-term, right? If we look at the results, they looked at 15,000 teeth, and they randomly selected 420 teeth, and they looked at the survival rate is 81%. But if you place a crown immediately after the root canal treatment, success is 90%. Now, if we look at the failures, out of the failures, 6% of the failures are because of bad endo treatments. 35% due to root fracture, and 21% due to caries. So more than 50% of the failures has nothing to do with root canal treatment. In fact, it doesn't matter how beautiful your root canal treatment is. Fractures and secondary caries has nothing to do with how beautiful your root canal treatment, so that's why it's higher. Okay, so again, the benefits of vital pulp therapy. We delay the restorative cycle that we talked about. In cases where there is a mature tooth, we get continuation of root formation. It's less invasive procedure. Root canal treatment is considered invasive شوية. It requires less invasive restorations. You don't have to put crowns. Preserve the defensive and sensory functions, and that is important. The defensive, when you have a secondary caries in a vital tooth, it can protect itself by tertiary dentin, it can protect itself by blocking the dentinal tubules, whereas if it's root treated, it won't have this defensive mechanism. Also, it has a sensory function. So if you get caries in a root-filled tooth, you wouldn't feel anything at all. But if it's vital, you might feel pain, right? So this is a sensory function. Vital teeth have significantly higher proprioception. That was proved in the 80s by Stanley. Root-filled teeth showed higher caries susceptibility according to Mirdad in 2011. So many benefits. Currently, vital pulp therapy is not really popular, especially among general practitioners. And this was published, I think, last month. It's a survey to see which dental schools in the US teach vital pulp therapy. And this is a problem that we never learned in dental school, how to do vital pulp therapy. So what they found is that تقريبا 50% of dental schools, they teach them in simulation labs. And it's a 50% in newer schools, but in the older schools, it's around 30% that they teach it in simulation. If we look at who teaches vital pulp therapy in these schools, in newer schools, it's divided between endodontist, pedodontist or pediatric dentist, and also general dentists. In older schools, mainly endodontists teach vital pulp therapy. So there is a need now to focus on this and to teach in dental schools. Now, to answer this question, is vital pulp therapy possible? If you wanted to understand it, you really have to have a background in different areas of endodontics. First of all, you need to have a little background on dental materials. We'll talk about that. And then you need to understand the pulp biology and how does it respond to caries and how does it respond to different dental materials or capping materials. You also need to understand the limitation of pulp diagnosis and the diagnostic tools that we use. You need to read some papers on the history of vital pulp therapy and see why it failed in the past and what kind of methodology they used in these papers. Obviously, it goes without saying, you have to read the outcome studies that is available. فيهم عدد كبير جدا. I'm not going to be able to cover all the outcome studies. I'm going to summarize it, show you, and then it's up to you if you wanted to read more about these outcome studies. And finally, you need to read the recent position statements, both اللي من ال AAE وال ESE. I will try to summarize it at the end, but I encourage you really to read it. Let's start with the dental materials. This is a very interesting review article by Backlund and Andresen, and they wanted to see in trauma, can they replace the gold standard calcium hydroxide with MTA or not? And they showed how the pulp responds differently when you use calcium hydroxide or when you use MTA. Let me quickly explain the difference. When you use the calcium hydroxide, Yes, it's biocompatible. Yes, it stimulates sclerotic and reparative dentin. But the problem with calcium hydroxide is that it doesn't seal. As a material, it doesn't seal. It's very fragile. In fact, you can scrape it with any instruments. So it dissolves, it has a low mechanical strength, and it leaves tunnel defects. Now, when you place a calcium hydroxide directly on the pulp, what you get is that you have different layers. You will have the liquefaction necrosis layer, this one here, and then you have a coagulation layer, and then you will have your calcified bridge. This layer here, the liquefaction necrosis layer, it will dissolve, and then it will be empty, and that's why it causes tunnel defects. Let me show you how tunnel defects look like. This is a paper that was done by Goldberg in 1984, and what he did, he actually placed calcium hydroxide in premolars that is going to be extracted for ortho treatment. So he opened the pulp, placed calcium hydroxide, closed it for 3 to 4 months, and then he extract these teeth, and then look at the calcified bridge under the microscope. And what he found is that he found these tunnel defects. This is going to be a problem and challenging. If you take an X-ray of this calcified bridge, it will look beautiful on the X-ray. But what you don't see is that these tunnel defects. So if you lose the permanent restoration, if you get marginal leakage, these tunnel defects are highways to the pulp, and it's going to cause necrosis in the long run. And that's why calcium hydroxide papers and studies, they're very successful in the first year or two, but if you give it some time, they all fail, okay? And that's interesting. If we look at the MTA, or the calcium silicate materials, the same, it's biocompatible, stimulates sclerotic and reparative dentin, but the good thing is that it has a great sealing ability. And it gives you a beautiful calcified bridge compared to calcium hydroxide. Once you place the MTA, what you get is just coagulation layer, and then you get your calcified bridge. That has been shown in many histological studies, as well as clinical studies. People who've placed calcium hydroxide, MTA or bioceramic, when they remove it completely, the calcified bridge usually underneath it is completely mafi tunnel defects. Okay, so let's have a look at this, another review article that compared, but this is more clinical, يعني مو شرح الفرق ما بين الماتيريالز. And they showed that the MTA has a higher success rate compared حق calcium hydroxide, and it appears that MTA is suitable replacement for calcium hydroxide. It took us many years to realize that calcium hydroxide really is not a good material, so please do not use it. Okay, another clinical study that was published in 2019, and they included 17 papers. And if you know how to read the forest plot, basically, if this diamond doesn't touch the middle line, there is a significant difference that favors the MTA compared to calcium hydroxide, and showed in 17 papers these results. Okay, let's finalize the dental materials. Please do not use calcium hydroxide anymore. La dical, la sitting, la non-sitting, كلهم, they're not as good. And you can use any calcium silicate cements. The materials that I know is the total fill from FKJ. هذه مو دعاية. I'm not associated with any company, by the way. Endosequence, they're هم نفس الشيء. اللي ينباع بأمريكا الإندوسيكونس اللي ينباع عندنا ال FKJ, they come from the same company in Canada. You also can use the MTA from Dentsply, or you can use the Biodentin from Septodont. The majority of the studies, they use these materials. I'm sorry حق الشركات بس they usually come to me with different materials اللي من البرازيل اللي من كوريا I don't know them. Okay, and if you wanted to use any material, it may be good, I don't know, but you need to find papers that is published that shows that it works. Okay? Enough with dental materials. Let's move on to the pulp biology. Pulp biology is interesting. This is a heavily carious tooth. And my question to you, is this definitely inflamed pulp? Is it inflamed or not? Can it be healthy? Is there a chance that this pulp underneath this caries is healthy or not? And this is what I wanted to ask and show you why I'm asking about this. Now, we know that as soon as you get enamel caries, you can get inflammation. This is احنا عارفينها من زمان. If it goes deeper, you get more inflammation. But does the pulp has a capacity of healing even if it becomes inflamed or severely inflamed? Does it have the capacity to go back and be healthy or not? Many people don't believe that, but I'll show you in this paper that was done both on humans and monkeys. What they did, they exposed the dentine to bacteria, and then they started extracting teeth. In بعد 12 ساعة, after 20 hours, after 32 hours, after 1 week, after 30 days, and they wanted to see if these pulps, with time, can heal after you expose them to bacteria. They found the highest inflammation will be after 32 hours. You can see the inflammatory cells against the dentine, والبكتيريا داخلة من الدentine, okay? But after 30 days, the pulp goes back completely healthy with tertiary dentine. So within limits, the pulp, even if it gets inflamed, it can go back to be healthy, right? And that is if we understand الكيريز as a behavior. الكيريز is not gangrene. يعني الكيريز doesn't continue بشكل مستمر. It's dynamic based on the behavior, right? So if you get more cycles of demineralization, the odontoblast is likely to die and the pulp is likely to be necrotic. But on the other hand, if you get more remineralization cycles, what happens is that the odontoblast have enough time to build tertiary dentine and build higher quality dentine and block these dentinal tubules, okay? So think about caries when you look at it. شوف الcaries, is it arrested or not? Is it white شوية? Is it darker? Think about the behavior of the caries, and based on that, you can estimate or assume what is the pulp status is. And we already know that the pulp has different mechanisms, how it protects itself. You get dentinal sclerosis. Usually, the dentinal tubules are permeable, بطلين, in healthy teeth. But if you get caries, the permeability of these dental tubules will be constricted. It can go down to 20% and sometimes completely block the dental tubules, and that protects the pulp from caries. We also get tertiary dentin as well as immune response. Altogether, these responses can actually, if the caries is not fast, the pulp would have enough time to protect itself. So, in a nutshell, the slow progressing caries, the healthier the pulp. The fast progressing caries, the more the inflamed the pulp, right? So, this is a perfect example on how a tooth with very deep caries can have a healthy and completely healthy pulp. With tertiary dentine, completely sclerotic, that is blocked, ما في bacteria dish, خلاص the pulp will protect itself, right? Now, so things to think about is how fast the caries and what is the condition of the current lesion. We talked about that already. Now, this is a patient, هذا نفسها اللي حطيتها قبل شوية. She had this lesion for more than 10 years. Caries. She brushed it. She doesn't want to do anything with it, which is interesting. I tested the tooth and it's vital. There's no any symptoms at all. And they told her it's up to you if you wanted to do anything or not. Now, let's assume there is inflammation in the pulp. How does the inflammation progress in the pulp? Does it go in increments? Or the whole pulp gets inflamed altogether? This is what we need to think about now. In the past, we had this strangulation theory, and basically what it means, if you get inflammation, the whole pulp will get inflamed, and then it will strangle itself at the apex, and then the pulp will be necrotic, right? But many papers have actually proved that it's not true. Both physiological studies, such as Van Hassel, showed that the increase in pulpal pressure is localized at the site of the lesion. The rest of the pulp is completely normal. Doesn't exist in strangulation theory. Also, histological studies showed that the inflammation is very intense at the site of the caries, and the rest of the pulp is completely normal. So it doesn't make any sense that the pulp strangle itself from inflammation. In fact, many studies have اكتشفوا بالصدفة that inflammation is only localized at the site of the infection. Mitchell Trapley showed that only rarely did the inflammation extend into the root canals, and usually the radicular part, the part at the roots, is usually healthy. Okay. So, in summary, inflammation is by increments. Start at the site of the infection, and then 2 millimeter, for example, and then it goes 2 millimeter, and then it goes 2 millimeter. Why is this important? Imagine if we remove this part and we cap the tooth, do we expect it to heal or not? Yes, صح? If we remove it. And because it's increments, if you see a patient that has a vital tooth, it's positive to cold, even if it's inflamed, you know that the inflammation is somewhere close. It's within 2 millimeter, within 3 millimeter. It's not far away. Otherwise, if the inflammation goes all the way down, then the pulp is not vital anymore, right? It won't respond to cold test by definition. Unfortunately, the most of the cases that we see, we don't know how deep the inflammation is. What we do is that we actually assess the inflammation by bleeding time. This is the only thing, it's not a good marker, but it's the only thing that we have. When we do vital pulp therapy, we see bleeding. If we can control it, then it's fine. If we cannot control it, we assume that there is more inflammation, and then we have to go deeper, right? Okay. Let's move to the limitation of pulp diagnosis. And that is one of the areas that we're struggling with. I want you to imagine this line. On this part, we have a healthy pulp. This part, we have a pulp necrosis. And in between, we have reversible and irreversible pulpitis, right? So the question is there a pinpoint where we can tell exactly if the pulp goes from reversible to irreversible based on diagnosis, based on cold test, EBT, history of the pain? Can we tell? Unfortunately, we cannot. And هذه أحد العيوب اللي we're struggling with, that our test cannot really differentiate between reversible and irreversible pulpitis. And what's even more confusing is that we know that 40% of teeth, they go all the way to necrosis without pain. So you can see confusion, and that was, I'll show you the paper by Michelson. Now, the correlation, basically what this means that do our clinical signs and symptoms correlate with the pain or not, correlate with reversible and irreversible or not? Many papers have showed that there is no correlation between the two. There is only one paper by Rikuchi that have showed correlation between reversible and irreversible. It's only one paper. It hasn't been repeated. But that doesn't mean that we cannot do vital pulp therapy. لأن أكثر واحد سوى vital pulp therapy Rikuchi. Okay? It has some problems, this paper. They assume that irreversible pulpitis when you have bacteria in the pulp, which is, if we remove it, then we can do vital pulp therapy, right? Another problem with this paper is that it doesn't explain painless pulpitis that go to necrosis without any pain. And this is the paper that I was talking about by Michelson, is that 40% of teeth, they go to necrosis without any pain at all. Okay, let's talk about this paper. This is the consensus that was done in 2009 by Linda, and what she did is that she came up with the 2009 AAE diagnostic terms that we use today, right? And if we look carefully in this paper, you can see that she mentioned that currently differentiating between reversible and irreversible pulpitis is largely done on empirical basis, and we cannot really know if it's truly irreversible. So the AAE, they admitted from that time, but we don't have any studies to prove vital pulp therapy at that time, or enough studies. If we look at the position statement of the European Society when it comes to reversible and irreversible, at this moment it is accepted that diagnosis of irreversible and reversible pulpitis are clinically based terms. And they came up with a suggestion that there have been calls to consider new, more representative way to classify pulpitis, NIFs, partial irreversible pulpitis. Partial, I mean, I agree, partial irreversible pulpitis. لأن if you say the term irreversible, then it's automatic root canal treatment, right? But if you use the term partial irreversible pulpitis, then you can remove the irreversible part and then you can do vital pulp therapy. And I'm talking about the best terms. Also, the position statement of the AAE in 2021. Today, the focus of vital pulp therapy is broader. Practitioners may have the treatment options to consider other than pulpectomy or root canal therapy in mature teeth, including teeth previously thought to have irreversibly inflamed pulp. So according to the AAE, irreversible pulpitis is not irreversible anymore. Okay, let's move on to history. There is, I don't want to spend a lot of time on history, but you know this paper by Schweck in 1978, where they did their trauma cases and they used calcium hydroxide, and it was successful, right? And that's why, وبناء على هالpaper, we got the terms mechanical exposure, or after trauma, you can do calcium hydroxide. But if you have caries exposure, then it has to be root canal treatment. And this is where it came from. Also, another paper that is usually used against vital pulp therapy is Bartel. And what they did, and these cases are done by dental students, the success in 10 years is 13% by using calcium hydroxide. Okay? And based on this paper, a lot of people gave up on vital pulp therapy. This is also a beautiful study by Biondal. It's multi-center, 2 parallel groups, patient blinded, They did two phases. الفيز الأول they did stepwise excavation compared to direct complete excavation. طبعا what they wanted to know is that the risk of pulp exposure, okay? And then they extended the paper, the study, to compare two other groups, and that is the direct pulp capping and partial pulpotomy. And they had really very low success rate, and that is 30% and 34%. This is the history. Also, we had historical myths. We can only, in the past, we can only do vital pulp therapy on small, traumatically or mechanically exposed pulps. You remember that? Only uncontaminated exposed pulps. If it's contaminated, you have to do root canal treatment. Exposed pulps of caries tooth or previously restored tooth, that was also in the past, not anymore. Older teeth because of normal age changes such as increased fibrosis. And that has been disproved because the majority of the patient group in the newer studies are adults. Okay? Okay. We're good with time. Let's move on to the outcome studies. And it's impossible to go through all the outcome studies. I'm going to select a couple. And that is by Witherspoon. And what he did is that he did full pulpotomy in young patients, and these cases are symptomatic teeth. So he had a very high success rate, and only, I think, one case that have failed. And he was one of the early people who used MTA to do vital pulp therapy. And you know, MTA was developed in 2000 تقريبا نهاية التسعينات, بس clinical trials are usually slower. Also, a beautiful study, a case series, was done by Bogan in 2008. He's very skilled clinician, and the patient group, as you know, he extended it to 45 years old. In the past, كان في مشكلة إن في تخوف من doing vital pulp therapy on adult patients, but he was one of the first who actually showed that it works. So these are example of the case. He stopped the bleeding by using sodium hypochlorite, either by irrigation or by using cotton pellet with sodium hypochlorite. Once the bleeding is controlled, he would fill the whole floor with MTA, and that is thick MTA. And the key really is to fill the whole floor. And the mistake that I usually see is that when you have exposure, pulp exposure, you only focus on this pulp exposure, and you forget the thin dentines in the floor that is there. Okay? So 53 cases, age group 7 to 45. He had 98% success rate in 9 years. Now, case series are good to show that it works, but usually it's not generalized, because just because he's skilled, it doesn't mean that everybody can have the same success rate, okay? So that's why clinical trials are important, and this was done by Qudaymat. So Witherspoon and Bogan showed that MTA works. Now we wanted to compare it to other materials, such as calcium hydroxide. He did partial pulpotomy, and that was published in 2007. Used either calcium hydroxide or MTA. ما كان في فرق كبير ما بين الcases. I don't know, I assume it's because they didn't follow them for a longer time. Also, Menti did compare calcium hydroxide to MTA, and this is a retrospective study that was done between 2001 and 2011. So it's a retrospective, compared both materials, and found that, hold on a second, okay. So he had caries exposure, and this is good. It's not mechanical exposure. 2029 teeth recalled. MTA had 88% success rate, 73% success rate after 4 to 11 years. Calcium hydroxide, however, 50% success in 3 years. Another interesting paper by Hilton. What's good with this paper is that they took people who are good with MTA and took people who are good with calcium hydroxide, different practices, and they did تقريبا 180 cases in each group. And then the probability of success of calcium hydroxide is 68% compared to 80%. So he took people who are already skilled in calcium hydroxide, people who are already skilled in MTA, and compared the both groups and showed that MTA is better. And this paper also interesting because they wanted to see the different age groups and the success rate between the different age groups. And what they used is they used bioidentine. And you can see that if the patient is less than 20 years old, success is very high. A little bit lower if it's 20 to 30. And then 40 to 60 years is almost 80%. But that doesn't mean we shouldn't do vital pulp therapy on older patients. If I get success of 80%, I'll be more than happy, honestly. So, okay, now, direct pulp cap. I have divided these outcome studies to different groups. Direct pulp cap, partial pulpotomy, full pulpotomy, and then I did another group, which is reversible pulpitis and irreversible pulpitis. And really, I don't want you to focus on the details of these papers, but I want you to focus on the age group when you read these papers. Look at the majority of these are done on older patients. Also, when you read these papers, focus on diagnosis, reversible or irreversible or mixed, root maturity, which material they use, and the follow-up, and you can have a sense of the success rate of direct pulp cap. Partial pulpotomy, the same issue, the same thing. في couple of studies, and again, في another thing is that sometimes you don't know if the case is a direct pulp cap or partial pulpotomy, and the definition between the two is مو واضح شوية. Once you get exposure and you stop, is this direct pulp cap? If you remove a little bit, 1 millimeter, is this a direct pulp cap or partial pulpotomy? And by the end of this, I'm going to give you a flow chart of how to deal with these cases before you treatment plan it. Full pulpotomy also is very popular. In fact, it's older. Even with calcium hydroxide, it used to work, especially in class 1 because the leakage is not as high if it's class 2. Chalishkan did interesting papers. The majority are irreversible pulpitis. But you can see that the success rate ranges from the 80s to the 90s. Now, if we look at, I did some calculation. I pulled the studies, and you can see in reversible pulpitis, we have around 28 studies. I pulled the number of teeth, it's 2,500. Average follow-up is from 12 to 24, and the age range from 6 to 88. Success rate ranges between 56 and 100%. The average is 87. Now, there's only one paper that the success was 56%. So maybe that's an outlier, we don't know. Because if we compare it to irreversible pulpitis, there is around 14 studies that looked at irreversible pulpitis, 1,000 teeth. It includes direct pulp cap and full pulpotomy, and the success ranges from 78 to 100. So by looking at this, you might think that irreversible pulpitis has a higher success rate than reversible manageable. So let's move from clinical studies to review articles. And This is by Gweiler, and they had 23 relevant articles, and the direct pulp cap تقريبا 1,000, partial pulpotomy 200, full pulpotomy is 190. Success rate ranges between partial pulpotomy and full pulpotomy high compared to the direct pulp cap, it's lower, 72%. I'm trying to push أسرع شوية عشان الوقت. So it's تقريبا نفس الشيء most of the review articles. So now you have a permanent tooth, whether it's open or closed apex. You remove the caries completely, you get a pulp exposure. If you don't get pulp exposure, you can place calcium silicate base bonded filling, and that's it. However, if you get a pulp exposure, then you expose the pulp enough to allow visualization, and this is key. You want it to look at the pulp and see if it's vital or if there is any avascular tissues or dentine chips. This is extremely important. When you get pulp exposure, don't stop or be scared of pulp exposure. You have to make it bigger a little bit, okay? You try to control hemorrhage for 2 to 10 minutes with sodium hypochlorite, that's fine. أنا أشوف في ناس شوية تخوفهم من sodium hypochlorite, you shouldn't. And then, if you control bleeding, then you can immediately do a direct pulp cap. If you don't, then you remove a little bit as a partial pulpotomy, or you can go ahead and remove the whole floor of the pulp, and then try to control bleeding again. If you couldn't, then you go ahead and do root canal treatment. What does that mean? It means that with these cases, with this new procedure, we don't plan to do direct pulp cap or partial pulpotomy or full pulpotomy قبل العلاج. It's not just a pulp cap, it's a diagnostic procedure. So you open the tooth, you try to control bleeding, then you decide. If you can't, then we assume this is truly irreversible if bleeding cannot be controlled at all. Okay? So the procedure is diagnostic / ما نقدر نقرر من الحين whether it's direct or partial pulpotomy. It's confusing, I know, but with time you will understand, inshallah. General principles: bacteria control is important. Once you remove كل الكاries, you should be careful to change your burr, your instrument that touched the bacteria, so you need to think about that. Dentine debris control, you don't want to push any debris into the pulp. You have to be delicate with the pulp. Don't push it with the cotton pellet hard مثلا. You can control hemostasis by using sodium hypochlorite or saline. Avoid materials entering the pulp, سواء كانت fiber tissues من الcotton pellets. We can see that under the microscope إن في fibers من الcotton pellet. You can use caries detector. I don't use it personally, but it could be a good tool to use. And then immediate restoration is important. So بعد ما تحط البايو ceramic or MTA, place Vitrabond on top, and then you can restore the tooth immediately. Let me show you an example of, this is dentine chips, and you can see the shadow of the pulp underneath. This is very thin dentine on the left. If you expose it well, you can see healthy pulp, then you can place your bioceramic or MTA. The reason I'm saying is that when you get an exposure, when you get an exposure on this side and you only focus on this side, you might get very thin dentine on this. So you need to fill the whole floor بالsealing to prevent any possibility of marginal leakage. These images I took from Rikuchi paper. This is the avascular tissues that I was talking about. Sometimes it's yellowish or whitish, and sometimes it's bluish. So, and this is the image that you're looking for, a healthy pulp with bleeding control. And that's also another reason why visualization is important. Whether it's a very good loops that you use or a microscope, أفضل. If you cannot really look at the tissues, then you probably wouldn't have good outcome in the cases اللي تسويها. Future challenges. Currently, we don't know if we should do vital pulp therapy to compromised teeth that will need crowns. Is it going to work with it or not? We don't know. Hot teeth that might require intrapulpal injections. We had a couple of cases. Lower molars, we tried to do vital pulp therapy, but we couldn't numb the patients, and we had to do intrapulpal. Now, if you use intrapulpal, then you shouldn't do vital pulp therapy. You already damaged the pulp. Calcified pulp chambers, that's another case. We had a case that failed recently. Is it because the volume or the mass of the pulp is not enough blood supply? I don't know. Discoloration of anterior teeth is another thing to think about. I lean towards full pulpotomy with anterior teeth than direct pulp cap or partial pulpotomy, because you wanted to place the MTA under the CAJ. 5 minutes? Okay. I apologize. راح أعطيكم الزبدة بعد شوية. Okay, so this is a case, discolored. You can remove the MTA شوية تحت the CAJ and then you can bleach it. Now, let's move to the important position statement. الحين عندنا two position statements. عندنا ال ESE and the AAE. Both of these position statements, they both agree on vital pulp therapy. And we can do it. الاختلاف الوحيد ما بين two position statement is if the tooth is asymptomatic, we shouldn't remove كل الكيريز. هذا ال ESE. The AAE, we have to remove all the caries. And أنا شوية أميل لرأي ال ESE for one reason. So, hold on a second. If you read the ESE position statement, it's detailed. It's amazing, 9 pages, okay? And they had experts in cardiology with the authors, all right? And they had all these recommendations on how to do vital pulp therapy. But if you look at the AA, it's very humble, 3 pages. I think it was quick position statement, but they recommended removing all caries. Now, في شوية اختلاف ما بينهم ودنكن, who is the author of the IAJ, شوية معصب. So he wrote a letter to the editor where he wanted to defend the ESE position statement. Okay? That يفترض, okay, I can teach you how to do vital pulp therapy, but the majority of people, they don't use rubber dam. And the majority of people do not have good visualization. The majority of people don't have even MTA or bioceramic, right? They don't even have calcium hydroxide. So I cannot talk ideally في عالم غير مثالي. This is what Duncan is talking about. And if you read this, and then a global burden of caries and patient treatment need, do we expect that كل الcaries have access to dentists that have rubber dam or microscope or MTA? No. And that's why we should consider indirect pulp cap, because it's simple. You don't need rubber dam, you don't need a microscope, you don't need expensive materials. وهل هذا الاختلاف اللي صار ما بينهم قاعد يقول ان it's neither realistic nor practical that all deep caries should be referred to an endodontist. And we need to educate general practitioners in non-elitist fashion. يعني ما نكلمهم بطريقة نخبوية أو برجوازية إن مثاليين. لا, we need to teach the indirect pulp cap because it works أول شيء. It doesn't need لا expensive materials ولا equipment. إن هذا الاختلاف اللي صار ما بين ال ASE وال AAE. خلاص؟
I apologize صراحة, we ran out of time.
والله عندي معلومات بس يلا. Thank you everyone. Please, if you have any questions, let me know. عندنا question هنا. 2, 3, okay. عندهم mic? Okay.
Thank you, Doctor, for the presentation. I have a question. Do we sometimes do intentional direct inspection, even if we removed all the caries, especially in open apices where you are not sure as a diagnosis from your tests or from the history of the child? Do we sometimes, even we removed all the caries, do small drop, given that you are using a sterilized burr and the rubber dam to check for bleeding?
Okay, so why do you want to do that? في symptoms يعني؟
If you're not sure about...
ولا تبي تشوف vital or not vital?
Yeah, you want to... If you're not sure about the pulpal diagnosis, if it's
يعني it's whether it's vital or not? Yeah. I don't recommend doing that. Alternatively, what you can do is you drill it without anesthesia and see if the patient feels, then that's vital. But I wouldn't, يعني سؤالك يعني ماني مو فاهمه, but I wouldn't recommend just to go in just to see if the bleeding is controlled or not. I wouldn't recommend that.
Okay, thank you.
You're welcome.
شكرا دكتور سمحان على
حياك الله.
المحاضرة الجميلة.
في واحد يسأل دقيقة بس ثواني.
I'm sure إن في معلومات وايد كنت بتقولها, especially when it comes to the ESC and the AE. Well, I'm very curious about what's your opinion when you said that you're in favor of leaving caries behind. So there are two ways of, or two techniques were described in the ESE position statement. I just want to know, are you in favor of leaving caries and going back to remove it after having a tertiary dentine, or just leaving that caries?
Okay, good question. I actually like indirect pulp cap and leaving caries behind. I love it. I think it works. In fact, one of my teeth had this procedure 15 years ago, and it worked. So maybe I'm biased. But I wouldn't go back. If I do indirect pulp cap or partial caries removal or incomplete caries removal, كلها نفس الأسامي, I wouldn't open it again because the idea is to force the lesion to arrest. Okay? So if it gets arrest, then you don't really have to remove it. I know that if you do it to a case and then it goes to another dentist ويبطل يقول منو هذا اللي ما شال الكيريز كله. بس I would tell the patient also that I left caries and to protect the pulp. This is what I want the majority of GPs to do. I don't want them to do direct pulp cap or full pulpotomy because it's technique sensitive. It requires a lot of work صراحة.
No, so that's bringing me to the second question. Now, when we compare the success rate of indirect pulp cap to the success rate of having a partial pulpotomy based on doing it right, assessing the bleeding time and all that, assessing the tissue, isn't it having a partial pulpotomy, or spheric pulpotomy, or direct pulp cap, if it's done on the right way, have a better success rate when it's compared to indirect pulp cap?
Yes, it has a higher success rate.
Oh.
But if it's done correctly, يعني under microscope.
Oh, thank you.
You're welcome.
Thank you.
One question. One more question.
والquestion عقب المحاضرة إن شاء الله. تفضلي.
Thank you, Doctor, for your informative, up-to-date lecture. My question is more clinical. So you said for hemostasis we can use either sodium hypochlorite and saline. So for sodium hypochlorite, we know that one of its properties is dissolving tissue. So what do you recommend if you're not using cotton damped with this?
We use it as irrigation. We don't inject it into the pulp. It makes sense, your question. But if it's injected into the tissues, it will actually dissolve the tissues. So we don't worry too much about it. And the information about sodium hypochlorite came from these studies. So I think it works. I don't think it will affect the tissues.
Do we need to irrigate it with saline after using sodium hypochlorite?
You don't have to. They didn't talk about that at all. Yeah.
My second question is regarding what considered a successful vital therapy, since pain is not one of the factors that we need to look at.
Good question. If the patient, I mean, مثل أي outcome measurements, سواء كان root canal treatments or vital pulp therapy or surgery, في parameters معينة we can use to see if it's successful or not. If you get calcified bridge, that's good. No symptoms, that's good. If it responds positively, you don't have to, but if it responds positively, then it remained vital after sometimes. That's good. So these are the things that you would worry about. Okay?
يعطيك العافية دكتور سمحان.
حياك الله.
We are sorry بس أساس نجهز.
معلش. Thank you, thank you, thank you.
All right, our next topic is going to be the future of endodontics by the one and only Dr. Jord van der Meer. A little bit more about him. He has a referral practice for orofacial pain and endodontics in Zwolle, the Netherlands. He also works at the University Medical Center of Groningen and at the Kolf Institute for Biomedical Engineering and Material Science, where he specializes in the clinical application of 3D technology like the cone beam CT, 3D scanners, 3D preoperative surgical planning, and 3D printing. His scientific publications focus on publication in 3D, applications of radiology like CBCT, MRI, and endodontics. The last few years, he shifted to more technical subjects like artificial intelligence and robotics in medicine. Since 2009, he has been Honorary Research Associate at the University College of London Eastman Dental Institutes. Please give it up for Dr. Jord.
Thank you. Thank you very much. Thank you also for the kind invitation. On the left-hand side, you'll see a picture of me when we visited Dubai, the Museum of the Future, which is a very nice museum. So if you're ever in Dubai, that's something I can recommend. By the way, I think my Egyptian colleagues, I think I have to congratulate you because of the soccer match of yesterday. So congratulations there. Did a good job. This is the Netherlands, just to give you an idea of what the Netherlands is like. We have it's not a very big country, we're a fairly small country. We have a population of 17.7 million people, so we're quite densely populated. And we're the 22nd smallest country in the world. So I saw a lot of similarities with Kuwait. For instance, when I left Amsterdam on Thursday, it was raining cats and dogs. It was really terrible weather. And when I got to Kuwait, it was still raining. So I felt right at home. So thank you for that. Actually, on the way here, it was raining again. So about 1/3 of our country is below sea level. So it's regained land from the sea. And the lowest point there is about 6.7 meters below sea level. And if you map that, then we have a little bit more rain than you, but if you map it, you can actually see that the blue part is actually below sea level. The light blue part is almost below sea level, which is why we worry about the warming of the Earth and the rising of the sea level, because if the sea level rises, we will lose about half of our country. So I don't know what we're going to do with all those people in such a small part of land. This is Amsterdam, just to give you a little bit of an idea of what Holland is like. This is Amsterdam City, and when you come there as a tourist, you will see all these bikes and the old city center. And when you zoom out, you'll get to the outskirts of the town with still a lot of old buildings which have survived the Second World War. But on the outskirts, you will get more modern buildings. And of course, you will see the canals, and we're very well known for being a biking country. So you will see all these bike lanes, which quite often interconnect to different cities. So you can rent an electric bike and visit all the different cities. And this is typical Dutch landscape, these pastures with a lot of cows. These are all nice pictures when it's not raining. So chances are that it might be raining when you come over, but this is typical Dutch landscape. And then when you come over in springtime, you will see the enormous flower beds, because we have a very good soil, but also a lot of water, so which is very good for flowers to grow on. And of course, the most well-known flower is the tulip, which around April, May will be present all around as well. And then you can buy for 10 euros, like 3 of your local currency, a big handful of these tulips. During winter time, we don't have any harsh winters like we used to, but the landscape may look like this with snow and ice everywhere. So if you decide to come in wintertime, it still may look like this. And if we have a very harsh winter, all the lakes will freeze up, and you're actually able to do some ice skating on the lakes and on the rivers, or the canals mostly, which is a very nice way of passing your time. So whenever you feel like coming over, springtime, of course, being the nicest, and the summertime when we don't have so much rain, but then I hope to see you in the Netherlands. I had to make a little bit of a commercial for the Netherlands, of course, to give you a bit of an idea of what it's like. Now, this is the Netherlands. We're in between Germany, Belgium, and the United Kingdom. And we have three dental schools. And three dental schools are in Nijmegen, the southern part of the country. We have ACTA University in Amsterdam. And we have the UMCG where I work in the northern part, northeastern part of the country. And we live strategically somewhere in Zwolle, so which is about an hour drive from each of these cities. Just to give you an idea of Holland, you can go from north to south in about 3 hours and east to west in about 2 hours. So that kind of gives you an idea of the size of the country. And this is where I work, the University Medical Center, which is like a small island in the city of Groningen. And I work at the Kolff Institute for Biomedical Science and Material Science, Biomedical Engineering, and my boss is Etienne Ren. And you may know the university because in 2016, Ben Veringa received a Nobel Prize. He shared that with 2 others on nanotechnology. He was able to build from molecules a small car, and if you shine light on the car, it will start to run. So it will actually run across a surface. And it's all made of molecules. But we'll get to that later about nanotechnology. When you look at the city I live in, Zwolle, this was a map on the left from 1651. And at that time, they didn't know what it would look like from above, but they used math to draw this map. But when you look at it right now, you can actually see they did a pretty good job, and you can still see the old moat and all the reinforcements of the city. They're still present in some form. And when I stand somewhere in a corner, somewhere on a Saturday morning, and I make a picture, then this is what you will see. So depending where you are, either in the air or on the ground, your perspective will be different. And playing with perspective is something that one of our artists has done over the years. His name is Escher. And when you look at his pictures, you will see there's something wrong with it. But it's very hard to pinpoint where exactly it is, where it went wrong. But it has to do with a perspective. And I hope to maybe change your perspective a little bit when it comes down to technology and what will be possible in the years to come. But of course, we have to look at the consequences of technology as well, because there are some downsides to technology as well, and that's something we have to consider. But when you look at, for instance, the consequence of technology, we know that from the year 2000 on, the traditional camera with a film roll in it, you could see a decline in their sales. And of course, the digital camera came up, and the film rolls weren't being sold anymore, which led to the demise of a company like Kodak, for instance. But the interesting thing is that around 2007, you can see a dip in the sales of the digital cameras as well. And I don't know if you still recall what happened in 2007. It was the introduction of the iPhone. And with the introduction of the iPhone, things suddenly started changing, and suddenly we could make a picture without carrying a camera. So the introduction of the iPhone did have a great impact. I mean, Kodak disappeared. It stopped, it ceased being a company. The photography shops that were omnipresent, they started disappearing, and everybody can make a picture nowadays. And it was also the introduction of the selfie, which didn't exist beforehand. I mean, it didn't make sense of making a picture of yourself with a normal camera. But with the introduction of the iPhone, other things happened as well. For instance, did you know that with the introduction of the iPhone, the sales of chewing gum went down? And it actually is true, and it has to do with the fact that when we're in the supermarket, the chewing gum is always at the cash register. And when you're in line waiting for your turn, you look around, and what do you see? You see sweets, you see chewing gum, and you think, oh, it's not expensive. Oh yeah, I need chewing gum. So you put it in your groceries. And nowadays, when you're in line at the supermarket, the first thing you do is you take out your cell phone and you start looking up on your cell phone whatever you want to do, WhatsApp messages or whatever, but you don't look around anymore. And that's why the sales for chewing gum went down with the introduction of the iPhone. So these are weird consequences we don't really take into account. Now this is a correlation, and there's a very nice book by, and a website from Tyler Vigan, and not all of these correlations are real relations, because I don't think there's a real relation between the number of people drowned falling into a pool and the films Nicolas Cage appeared in. Of course, it is a correlation statistically, but it has nothing to do with each other. And neither does the per capita cheese consumption and the number of people who died becoming tangled into their bed sheets. So correlations doesn't mean that there is an actual relation between those two. So that's something you have to keep in mind. Looking at the consequence of the introduction of new technology, I think online shopping, this is typical, I guess, for online shopping. People fitting shoes, ladies fitting shoes, and then asking for the password of the Wi-Fi because they're going to buy them online because they may be cheaper elsewhere. But what's the consequence for shops? What we see, at least in Holland, that shop owners, it gets harder and harder for them to keep their business, and it gets more interesting to have a business online. But still, my wife likes to go shopping for shoes and try them on. So she still needs a normal shop. So what do shop owners have to do? I think they have to embrace technology and make it part of their shop to make sure that they can survive. So it's a challenge for shop owners nowadays, at least in the Netherlands. But apart from this grim idea of the future, I think technology can help us. It can help us to achieve more predictable results. It can help us to achieve results at a lower cost. And it can help us to make very difficult things easier. And when can we apply these principles in dentistry? And I think, well, when you look at how technology evolves, it's not like a straight line. It's not a linear trend. It's an exponential trend. So it starts off slowly and then suddenly it shoots up in the air. And that's something that you can find, for instance, in microprocessors. This is called Moore's Law, where every 2 years the processing power of a computer chip will double. And if that, it was not really stated by Gordon Moore in the 60s as a law, but some people now call it Moore's Law. And it still holds. And the interesting thing is, if you know such a law, you may be able to predict the future a little bit. For instance, you can predict, if it holds, when you can buy a $1,000 laptop with the same processing power as your own brain. And that'll be around 2030. And then if it still holds, you can predict when you can buy a $1,000 laptop with the same processing power as all the brains of all the people in the world. And that'll be between 2060, 2080. Those are going to be interesting times. I don't know what's going to happen. I don't know what the impact of that is, but it's interesting to think about it because it'll give you an idea of what the future might bring. So when you look at the future of endodontics, well, what is the current status? What are we developing? And what will be possible in the future, further in the future? And then what I want to do is just use our workflow to get an idea of what we should focus on. What are our weak points at this moment? And I think the weak points are diagnosis, access cavity, disinfection, obturation, restoration. I think those are the weak spots that we have right now. And I'll try to touch on each of those during the lecture. When you look at our diagnostics, I mean, what do we have as diagnostics? I mean, we can hammer on a tooth, we can put some ice on it, we can put a creme brulee burner on it, we can put some electricity on it, we can use the burr to burr a hole in it, and that'll give us an idea, looking at the response of the patient, what's going on. But still, it's almost like trying to follow last night's game when you're outside the stadium. So when you hear people cheer, you think, okay, maybe there was a goal, maybe not, but something happened, you know, something exciting. But still, it's trying to interpret what's going on inside. That makes it difficult. And then you may say, okay, but we do have X-rays. Yeah, of course, we have X-rays, but basically X-rays are like a shadow on the wall, and just a shadow on the wall doesn't always give us what the precise representation of the truth. And that's one of the disadvantages, because as a man, I do have an idea what will cast the shadow, because in my fantasy, I see a beautiful woman standing there. But of course, that doesn't have to be the reality. I mean, we can be fooled by the reality. So it's our own interpretation what we see on X-rays as well. That's why the Americans say, never believe an X-ray. Well, that's maybe a bit too much, but it does tell you what you should do with an X-ray, and at least be careful with it. And that's what you can see in the research as well. When you look at an X-ray and you give it to different examiners, the same X-ray, they will, well, agree in about 50% of the time. The other 50%, they will disagree among each other. But the interesting thing is, if I give you the same X-ray a couple of weeks later, you may disagree with yourself, with your previous diagnosis. So for us, it depends on whether you show me the X-ray on Monday or on a Friday, and how the week was and how the evening was. And depending on that, I will see more or less on the X-ray. So what about AI? I mean, couldn't we use that? Well, AI, of course, it's kind of exciting, you know. AI is being used already by all sorts of companies. And some people are very pro, some people are very against it. But I think it's already here, so we might as well take advantage of it. And you know, of course, the machine learning, this is what Google did. Google challenged the best Go player in the world, and with their computer was able to beat the best Go player in the world, which is very exciting, because Go is one of the most difficult games you can imagine. It's way more difficult than chess, for instance. And what they did is they used a technology called Google DeepMind. Well, Google DeepMind is open to anyone, and it's called TensorFlow. So if you have some time off tomorrow, you can download TensorFlow, and you can build your own neural networks, and you can train these neural networks in recognizing objects. That's what it's basically made for, recognizing certain images and certain trends, and that's what you can train it for. Now, the hard thing is that AI is, it's difficult to understand for us humans what's going on, how it works exactly. So it's like more or less like a black box. And this is one of the examples where at a heart department, cardiac department, they looked at the different parameters of patients, and the AI was able to predict who would live shorter than a year and who would live longer than a year. The AI was about 85% correct in that. And they didn't know how it worked, but I'm not sure. I don't want to know when I'm going to die. So for me, it's I wouldn't want to use such an app. But it shows you a little bit about what's going on inside. For us, it's too difficult to interpret. Basically, these neural networks have a lot of artificial neurons which are almost interconnected to each other. And based on the strength of their connection, a certain end result will come at the output layer. But what happens in between is kind of hidden to us. So we're not really sure how AI makes its decisions. And this is a very well-known paper from Samir Singh. And he looked at AI and basically what's going on the inside in those hidden layers. And this is an application that they made where AI was trained to recognize either a husky or a wolf. So it should discriminate between the husky and the wolf. And sometimes it went the wrong way, and it said, this isn't a husky, this is a wolf, when it was in fact a husky. And then they looked at how does it decide this? And what they found out was that the AI didn't look at all at the picture of the dog or the wolf, and it didn't look at the traits of the wolf or the dog. What it was actually looking at was whether there was snow in the picture. And if there was snow in the picture, it said it's a wolf. And if there was no snow, it's a dog. So the problem is that quite often we don't know what AI does, how it works. And that's something that we should focus on. Interesting fact, though, is these neural networks, they already got a special mention in this month's Time magazine, Best Inventions of 2022, and Pearl's dental AI software got a special mention there because it can more or less interpret your radiograph, and then it can tell you this is this tooth, it has a crown, it has a root canal, it has caries, and this is about the size of the lesion, and you should take care of this, you should, well, so this, it helps you with the interpretation. So this is interesting for us. And of course, we also have the Chromium CT, and the Chromium CT, of course, being a big volume and 3D data set, can give you much more information about your patient. The problem, of course, being that it's still quite expensive. The resolution is okay, but we would like to improve on the resolution. It does have problems with scattering with metal objects or filling material, and of course, there's the radiation. Well, concerning the cost, we know from Moore's law that over time, the cost will slowly go down, and that's something that we can relate to because we started at the hospital in 2008 with the first Chromium CT machine, and when we bought one a few years back, a new one, we could see that the cost drastically went down. So it's getting, technology is getting cheaper and cheaper, which is, I think, good for all of us. When you look at the diagnostic capabilities, well, the Chromium CT is very good and very able to differentiate between whether or not you have a periapical lesion or not. So for endodontics, it's a very interesting machine. It has a greater sensitivity, and it can help us sometimes when we don't really understand where the pain is coming from, and it can help us in certain cases where we have to plan our strategy for the treatment. So it's an interesting one. I do think that in the future, in the near future, we can see the resolution go up, just like we can see in our cameras. And I think the cost will go down, and we will get new algorithms that will help us to decrease the amount of scatter. So we will get better images for less money, bigger bang for a buck, as they say. What is interesting to me is, can we use MRI in dentistry? Because that's something that we're all looking at, and especially in using what they call coils. And coils are basically coils that you put inside the mouth. They don't have to be connected by a wire to the MRI, and it will give you a high-resolution image of that part within the coil. And some publications have been out there already. And here you can see one of the coils. I mean, the coils, you can make them yourself if you know the characteristics of the MRI. And you get these kinds of images, and when you look at the amount of detail that's in there, you can see the nerve and the blood vessels and everything. So you see a lot of detail. The only thing is we have to get used to is the image is inverted. So we see the watery things. We don't see the bony parts, but we see the parts that have a lot of water in them. So, but you can imagine that for a computer, it's not difficult to invert these images. And you can do a little trick with that as well. And there was a clever author who did this. They made a coil, and they used it to make a digital impression with an MRI. What they did is they brought the coil inside the mouth of the patient, and the little tube in there, you can use it to bring some water into the mouth of the patient, and then because there's water around the teeth, you can image those teeth very accurately. And this was the impression, if you will, that they made, and they were able to construct a bridge on basis of this MRI. So this is an impression made without any material at all. So I do think that this is an interesting technique to use for us and to make things easier for all of us, because it's looking through the tissues. When you're looking through tissues, of course, you can also think about ultrasound technology. And I know there's a couple of companies out there trying to make like an ultrasound impression tray. And here they have it connected to an iPhone. I'm not sure that that is the way, but already you can buy ultrasound probes which you connect to your iPhone, and then you can look through the tissues already and see different things and discriminate between the different tissues just using your own phone, because it has that kind of processing power. For endodontics, it would be interesting because it might give us a clue about where cracks might be in a tooth. So if we're able to diagnose cracks inside a tooth, like they do in pipelines where they use similar technology, that would be great, because cracks quite often can be quite puzzling when it comes down to diagnosis. So I believe this might be one of the diagnostic utensils that we might be using in the next few years. When we look at the access cavity, well, you can, if you have a cone beam CT, you can actually plan your own access cavity nowadays using software. There's different software developers that came out with solutions for this, and you can plan everything ahead, say where the access cavity should be, what kind of instruments to use, how much dentin you will have after you prepare the root canal. And this is available. It's something you still have to buy. It's not freeware, but it is available. And for students, it's interesting because we have at Acton University, there's a couple of these virtual reality trainers, the Simodont by Moog, where you can actually teach the student how to prepare for a root canal. Looking at realism, they're not as realistic as you wanted them to be, but if you have a cone beam CT, basically you can import the 3D data set, and you can kind of practice doing your access cavity before actually doing the endodontic treatment. And of course, we can use 3D planning for our endodontic treatments. I also use it, even though I've been having a referral practice for over 25 years. But the hard parts are those teeth that have obliterated root canals, usually connected to trauma years earlier. And we do know that about 27% of these will develop pulp necrosis and eventually some kind of periapical problem. But then it's very hard to find the root canal system, and that's something where you can use your cone beam CT like you would plan an implant, because you have a guide for an implant. You can do the same thing for your endodontic treatment. These are patients where you think, oh, that's going to be hard to reach the root canal system. But if you have a cone beam CT and you have an intraoral scanner, then you're able to plan the whole thing in advance, like you would plan an implant. Basically, it's the same procedure. You have to use the X-ray, you have to convert it to a 3D model, you have to plan the implants or your endodontic access, you have to design the guide, and you have to rapid prototype the guide. For the conversion, you can use very expensive software, but there's freeware out there as well. In Vesalius, you can use it to convert your cone beam CT to a 3D model or a 3D slicer. And then you can combine the 3D model of your cone beam CT with the 3D model of your digital impression. And you can do, of course, you can use expensive software like Geomagic for that, but you can also use freeware like GAM Inspect. It's a German software, and you can use it to combine the two. Very easy, 3 clicks, and you've combined it. And then you're set. Basically, all you have to do is design the guide, because then you can show in 3D software where your root canal system is. And designing of the guide is actually quite simple, and you can use freeware for that as well. There's Dutch software called Blender. I had to miss out on the Blender conference this year because I was abroad, but every year in Amsterdam there's a Blender conference. It's freeware, they use it for 3D animation. You can download it for free, and you can start making your own animations or design your own guides. Ton Roosendaal is the guy who started everything. And this is a guide designed in Blender, and once you have it designed, then all you have to do is rapid prototype it. This is what it looks like if you render it out in the software. And then you have to use a sleeve, of course, as well. I use German sleeves, which are made actually for endodontics. So you can use these sleeves and these burrs, this combination. They're very fine, thin burrs. And you can use them to find the root canal system. And it's almost like drilling for oil. And this was like 2 weeks ago. I had a very difficult case where also I designed the guide, I 3D printed it, and I placed the sleeve. And then it's like drilling for oil, because basically you place the guide and you know exactly at what depth you will find the root canal system. Why is this interesting? Because I believe that it took me 25 years to get the insights how to find root canal systems properly. So do I need it? Well, maybe I don't need it, but for a young dentist, you don't want to spend 25 years scouting for canals and finally having found the way on how to do it when you could do it very easily. So this kind of skips 25 years of experience, of endodontic experience, and anyone can do this, right? So that makes it a lot easier. This is where technology makes things easier for us. Scouting for root canals. In this respect, if you're interested, there's a very interesting application for Blender called Blender for Dental. And so Blender is free, but you can buy a couple of add-ons. And this is one of the add-ons, and it's called Blender for Dental. And you pay $250, and then you have the add-on, and you can design your own guides. And the interesting thing is that it also connects to 3D Slicer, the freeware that you have just used to make a 3D model of your comb CT. And here you can actually see it at work. This is the guide designer, so this is the software. This is where it was used for planning an implant. But here, this is how you design the guide. So it's very simple, and you can see that you can connect it to your 3D Slicer, your free software. And so your design is actually being shown in Slicer at the same time. So you can go back and forth between your 3D design and Slicer, and the changes that you will make will be converted into 3D Slicer at the same time. So at any point in time, you can exactly check, am I correct in where I plan my endodontic access cavity or my implant? So it's a big bang for the buck, I would say, for $250. So why not apical surgery? Well, you can do the same thing, and there's a couple of publications out there already showing that you can use these kinds of guides also for apical surgery, and even very fine micro surgery, where they designed a guide, and if you use the guide, it will lead you exactly to the root of the lower molar. Again, this is made so that basically anyone can do this kind of surgery. That's what technology is used for in this case. If you want to know more about it, there's a very nice book called Guided Endodontics. But also, if you say, I don't want to do it all this myself, you can also use software like CCOT software, where you can do the planning and they will make the guide for you. But if you like, you can rapid prototype it yourself, and that's what I do. And I think a lot of you will be doing that in the future as well. Maybe you're already doing it. Because when you look at 3D printing, these are all technologies for 3D printing, and the ones mostly used is probably the one on the lower left, which is DLP. Basically, it's like a light projector from below, and you project it through a container filled with flowable composite or bonding. You know, it's a light setting material, so a layer sets and then it's being lifted up a little bit, and then the next layer is being formed and lifted up again. So that's what's being used mostly. Now, you may be concerned about resolution, about price, or about speed. Of course, you can look at whether it's interesting for you to buy it or not, looking at the total cost of ownership. Concerning the resolution, this is what they can do already with 3D printing. This is done with a nanoscribe, but this is, the church is about, I'd say 75 microns, which means that you can place it on a human hair. So this is the resolution that's already obtainable with 3D printing, using, in this case, a nanoscribe. So it does take a bit longer. This is work from Jan Torgersen from Vienna University. He did his PhD there, and he's now at Stanford, if I'm not mistaken. At least last time I contacted him was at Stanford. And this is what he made. He made all these buildings and all these intricate details, and at a very almost molecular level. So it's very small. The nice thing about 3D printers is that nowadays we have biocompatible materials. This is NextDent. It's a Dutch company, but there are other companies. There's a German company. There's a South Korean company. Everybody's making nowadays materials that are biocompatible. And you can use them in combination with either their own printer. So this is a 3D Systems printer, which is very fast. It will print out about 10 models in about half an hour. It will print out a temporary crown in about 10 minutes. So you can already use it chairside. So they're very, very fast. And I like to use their surgical guide material because it kind of shows me when it's been through the autoclave. Because before autoclaving, it will be a bit orange, and when I autoclave it, the color will change and it will become completely transparent. And you can do that with basically cheap 3D printers. And the printers I use are now the Frozen Sonic Mini 8K. It has an 8K resolution, so it's like 21 microns is the resolution of the printer, and it's $700. I mean, that's not a lot of money for producing your own guides, if you will. So you may want to consider that. What are we working on? Well, we've worked on for the last few years is a 3D printable entomicrobial composite resins. So we're looking at if we can do clever things with the chemistry to make them antimicrobial. And well, we published something on this. And I did most of the printing work for this, and the papers started picking up on it. We're still waiting for companies to see if they're interested in making antimicrobial composite resins, for instance. And of course, I use it myself to make 3D models for my hands-on or for the students with different anatomical variations and challenges. So the problem is we're starting to have is that we're not allowed within a few years to use human teeth anymore. So we have to resort to these kinds of technologies to train our students. And of course, for students, it's interesting because they can prepare their cases by using a patient case and then 3D print the model and then do the endodontic treatment a day before they're actually performing it on the patient. So I think it's interesting technology, especially now when we're looking at the resolution and at the price of the printers. Then a small look at preparation. There's different companies out there who will all promise you the best things, and what they all are started doing is basically applying heat treatments to their nickel titanium, and with their heat treatments, their materials get less prone to cyclic fatigue or torque failure and cyclic fatigue failure. And it has to do with that their alloys are becoming more spread out. You don't have any, not the grain boundaries that you would normally have in the nickel titanium. And that makes them less prone to these kinds of failures. And of course, you can, after that you made your instrument, you can again subject them to heat treatment, and which kind of changes their characteristic, going slowly from an austenitic phase more into the martensitic phase. And because of the oxide layer on the surface, the thicker the oxide layer, the more it will go into the bluish color. And if the oxide layer isn't that thick, it will look like a gold wire, and beyond that it will look like a blue wire. If you go further, it will look like a green wire, but then it's becoming too soft. And there's companies out there that kind of combine them in one system. So the different M wire, gold wire, and blue wire. So that's what we're seeing. But it may not be the end, but because it may be that we're going into shape memory ceramics. So ceramics are able to show the same characteristics that nickel titanium have. So maybe the next generation of instruments may be made from ceramics and not from metal anymore. But we'll see. Interesting developments there. Disinfection, the hardest part of the endodontic treatment, how to disinfect, and the problem there is that bacteria have a tendency to form a biofilm, and where they use extracellular polysaccharides to make like a coat, to stick them onto the surface, and the longer you wait, the thicker the coat gets, and for them, it's like a surplus of food. It's like food storage, but also to protect them from chemical and mechanical attacks from the outside. And it's a very good way of surviving. And they are very clever. This is from last month. This is a publication where they used the Candida albicans to move over the surface. So apparently fungi and bacteria, they work together, and this helps them to move across the surface. So there's a lot more interaction than we know. It's not only bacteria, but it's the fungi as well that help them to survive. And the biofilm itself has viscoelastic properties, so you can stretch it out and you can pound it, but then the forces are being spread out very cleverly, which protect them from mechanical forces. And that viscoelastic property is very hard to break. So breaking a biofilm is very difficult. And what we do is, of course, we throw fluids at them, but that's not enough. You really have to stir up the fluids to get that biofilm off the walls. And one of the guys that did his PhD is Bram Verhagen. He's into fluid dynamics. He's a physicist. And he did a lot of computer calculation, but also some high-speed recordings with simulated biofilm. And here, this is a recording of simulated biofilm, and it's very high speed, so you don't see the movement of the ultrasonic file, but you see movement of the particles, and suddenly there will be one bubble going across the whole surface and taking the whole biofilm off. And that's interesting, because that would be something that we could use in the disinfection. Also, we could use nanotechnology for our disinfection. And when we think of nanotechnology, you usually think of things like the buckyball or nanosheets or nanotubes. But you can use nanotechnology, of course, in small particles to smother bacteria with small particles like silver or gold. And that's something that we already do. They try to incorporate it in the filling material itself. The problem with nanoparticles is they're very hard to get rid of. So you can't clean them up because they're too small. For me, it's interesting because we can use nanotechnology to build little nanobots. And that's something that, of course, Ben Veriga did with his little motor. And this is his little car, the publication of his little car. And of course, it's all based on the isomeric properties of molecules. When you shine light on it, it will flip around. And when you shine light on it again, it will flip around. And you can use temperature to influence these movements as well. And you can build little robots out of them. And I think that's something that's happening right now. This is a publication where they built micro robots, basically 3D printed these micro robots. And they can change they can make a move. Usually you steer them with magnetic fields, and they have a small mouth you can open by changing the pH. And the claws of this little crab can open and close by changing the pH of the solution. So you make them magnetic, and then you steer them to a certain point and where they can start grabbing bacteria, for instance. But I imagine that these robots can become smarter as well, and almost the size of blood cells, and that's something that a lot of groups are working on at the moment. microscopic robots. These are about 150 to 200 microns, so still a little bit too large. But the interesting thing is they do have like an electronic mind. They have a microprocessor on board, and they're able to move, so you can tell them where to go. And they're very clever, and you can build them yourself. Basically, it's the same way that you build electronics. So it's lithography that you're using as a basis, and you give them a clever mind. So this is something where I think this might happen eventually, where we can tell the robots to, like the little bubble you could see going across the surface, you can make these little robots go across the surface, cleaning off the biofilm. The only problem is we still haven't figured out how to get them back into the garage. So you can't have them in the root canal forever, right? So that's interesting. And the other thing that we're looking at, and I'm almost at the end, is quorum sensing, where when you have two bacteria and you bring them together, and it goes, of course, for groups of bacteria, they will start communicating with each other. So they have like signals, biosignals that they talk to each other. And we know a little bit about those biosignals because they're all have the same basic chemical compounds, and they're all homoserine lactone rings. And then they have this long tail, and in the tail is the command or the thing they want to say. We don't understand the language yet, but it's interesting because apparently we see in nature that there are certain signals or a certain combination of signals where they say to each other, okay, so let go. It's not interesting to attach to the surface, or let's go somewhere else. And then they all let go at the same time. We haven't figured that out yet, but that would be interesting because if we're able to figure out that language, then we can incorporate it into a solution we can use in endodontics. And the whole biofilm in the root canal system would let go of the walls and we could rinse them out. Or, better still, we could make a mouth rinse, and then your patients can rinse their mouth and they wouldn't have any plaque anymore. That would be interesting, huh? Yeah. What will happen to dentistry? I don't know. But we know there's, in nature, there's like the Delicea pulchrae, and it's in an algae in Australia, and it has different biosignals. About 96 were found, and they were able to isolate them, and they built them here into plastic. And you can see exactly which plastic container was treated with those biosignals, because you hardly see any growth on that. So it's something where we looked also into if we can do something with it concerning our endodontic treatments, and maybe either disinfection or obturation material where we could incorporate it. And in the last part is basically the obturation, where I think if we were able to nano-coat the walls, then bacteria couldn't adhere to them anymore. That would be the perfect way to treat them, because if bacteria can't adhere to them anymore, they can't form a biofilm, and it would be a lot easier for us to obturate the root canals just by coating the walls and then filling up the rest. Restorations, well, what we need is long-term bond strength. Where it will lead, I'm going to tell you that next time, because I've run out of time. Thank you very much.
Thank you so much, Dr. George, for this very informative and up-to-date presentation. And the floor is open for a question. Anyone have a specific one? Jenna?
First of all, you are welcome in Kuwait. We are very thankful for your informative lecture.
Thank you very
And I
much.
want to ask you about, you told that biofilm is resistant to mechanical removal, okay?
I'm sorry, I couldn't hear you.
Biofilm is resistant to mechanical removal.
Biofilm, yeah, it's very resistant,
Okay.
yeah.
And
You can look at your patient, and like when I send my kids away to school
how
camp,
we need to remove the biofilm?
How can we remove it?
Yeah.
Yeah. We're looking at different ways of removing it. Ultrasonic irrigation is one way, because if we're able to generate very strong currents in our solution, then we're able to get them off the walls. But still, it's very difficult. But the bacteria in the biofilm, they're sensitive to the forces. And what we see is even after a week, after we've done ultrasonic irrigation, they are still dying off because of the impact of the ultrasonic waves. So ultrasonic does something. So it is a way of getting rid of biofilm. The other one is laser. If we're able to agitate the solution with laser pulses, and sweeps is an example of that, the sweeps tip from Photona, then you're able to generate enormous forces within the fluid, and that does get rid of the biofilm. Yeah, yeah. But it's very, very difficult. It's very persistent. Yeah. When I look at my kids, if they come back from school camp, after 1 week, they have about 200 microns of plaque on their teeth, usually. It's very difficult to get it off. Yeah.
I think it's the main cause of failure also after endodontic treatment, sir.
The main cause of failure. Yeah, I do believe so. Yeah, yeah. And yesterday we did a course on the treatment, on how we see the treatment right now. And I think the disinfection of the apical part is the most difficult, because there's very little fluid in there. It's very hard to reach. Sometimes you have an air bubble in there which prevents any fluid exchange. So that's usually what makes it difficult. So I think you're right. It's the biofilm, especially in the apical area. Yeah.
Thank you.
Thank you.
All right, Dr. George, before you leave, we have just a small gesture for you.
Oh, great. Thank you very much. Thank you very much. Thank you. This is where we stand for the picture as well. Thank you. Thank you very much. Thank you. And have a nice day, everyone.
Care specialist in advanced general and special care dentistry. She graduated with honors from University College Cork in Ireland in 2008 and went on to get a master's and fellowship in general dentistry from the Royal College of Surgeons in Ireland. Dr. Salaf also has a Kuwaiti board in general dentistry and master in special care dentistry from University College of London, and has recently, in collaboration, authored the first ever international special care dentistry textbook published this year. Please welcome with me Dr. Fatma Sarraf.
Thank you. And welcome everyone to this very last lecture of the day. So I want to try to keep this interactive so that make sure nobody else is sleeping, because I know it's been a long day and we need to get through this as quick as I can. So my lecture is about bleeding patients, and I'm sure as dentists we've all encountered patients that have bleeding problems. So like Dr. Ala mentioned, I did a master's in special care dentistry, and I have a lot of people asking me, what is this master about? So what is special care dentistry? So just a brief introduction into what special care dentistry is. So basically, it's a specialty. It was, according to the BSDH, in 2000, it's a 2008 specialty that was first established. And so basically, it looks at providing treatment and prevention for patients that have physical, intellectual, medical, emotional, sensory, mental, and social impairments and disabilities. So what does that all mean? So this means that we provide treatments for these types of patients. So patients that have developmental and learning disabilities, genetic disorders such as those that have bleeding problems, patients that have autoimmune disorders, mental health, physical disability, acquired disability, the elderly, medically compromised, severe dental phobia, and cancer patients. This is what the general specialty covers, but in Kuwait we tend to focus mostly on the developmental disorders and the genetic disorders and the cancer patients. And usually in the department we tend to see patients that are 12 and above, although the specialty is mostly for the older patients. So why am I giving this lecture? So like I said, I have a lot of colleagues that ask these questions, and so they keep telling me that this is a cardiac patient, we can't manage them. So they refer them to us. Can we do this endodontic treatment? Can we do the extraction? Can we do the restoration? The orthodontic treatment? Can we give local anesthetic? Can we do scaling if these patients are having bleeding problems? We also have patients that have been told that they can't have implants, or patients that can't have rubber dam placed, or crowns, or periodontal surgery. So this is the outline of the lecture. So I'm going to talk about bleeding tendencies, why they occur and how they occur, hereditary and acquired bleeding disorders, the categories of blood thinners, which is mostly what my lecture is going to focus about, because I think it will be more relevant to the colleagues, especially in the general practice, and how do we manage these patients. So we can't talk about bleeding without going over the coagulation cascade. So I'm going to bring you back to physiology, second year physiology. And so simple steps to the clotting. Does anybody remember how clotting happens? If you know it, just shout it out. Yes, clotting cascade. So first of all, we have a tissue injury. So once a tissue injury happens, we have vasoconstriction. And then this is followed by platelet aggregation. So all the platelets go to the site of injury. This is then followed by the intrinsic and extrinsic pathways. So the extrinsic and intrinsic pathways, they result in coagulation. And then this follows in the formation of the fibrin clot. So this results then in coagulation. So this is a very simplified version of the coagulation cascade. Okay, so why do bleeding disorders happen? So bleeding disorder happens means there's a defect somewhere in the bleeding cascade. So if you like, there's either platelet disorder or a coagulation disorder, a vascular disorder, or a fibrinolytic disorder. So in the clinic, if you have patients that come to you, so how can you assess if a patient has a bleeding disorder? So It's very important to ask with the medical history, ask these questions. So it's very important to know if they bleed easily, if they have frequent nosebleeds, if they have heavy menstrual periods, if they have prolonged bleeding or prolonged bleeding after dental treatment. So from these questions, by asking these patients, you can have an idea of what they have, or they might have some form of bleeding disorder. So if we look at the hereditary bleeding disorders, does anybody know any hereditary bleeding disorders? Again, shout them out if you know them. Hemophilia. What else is there? Von Bernbund, yes? Okay. You're special care people. Okay, so we have the platelet defects, and we have the prothrombin deficiency, we have the factor deficiencies, we have the Glanzmann syndrome disease, which is also a platelet dysfunction. We have the hemophilias, von Willebrand disease, thalassemia, and sickle cell anemia. So these are the patients that usually have hereditary problems. So these patients usually present to the clinic, to our clinic in special care dentistry. So they're not really encountered in general practice. And so I'll just briefly talk about how we manage them, because these patients have a certain protocol to follow. We can't really follow it in the general dental practice department. We have to follow it in a hospital setting. So we have the pre-treatment. So depending on the patient's condition, usually they're given blood products in the form of plasma, desmopressin in the form of hemophilia, before starting the procedure. And then during the procedure, we also have to have some precautions. So some of the precautions are, first of all, we have to avoid nerve block because we don't want to cause hematoma. We have to be very gentle with the trauma to the mucosa so we don't cause any trauma. We have to use sutures, and we have to prevent any flaps or surgeries that may cause excessive trauma. And then finally, after that, we may give them antifibrinolytic agents to prevent the clot from breaking down. And we may use tranexamic acid and advise them to use soft diet, and if in case they have any bleeding issues after 24 hours, to contact their hematologist. So these are the patients that we normally see in the special care unit. Okay? So this is a case of a patient. So these are the pictures of the patient, the way she presented in the clinic. So she came in, and this is what she had in her mouth. So the patient is a 16-year-old female. She was referred from the hematologist for bleeding gums. And her medical history is that she has Bernard-Solier syndrome. So Bernard-Solier syndrome, this is a patient that has a problem with her platelets. She's usually taking tranexamic acid, folic acid and vitamin C supplementation, and iron supplementation. So for this patient, the way in which we managed her is that we had to refer her back to the hematologist so that we can provide the blood products first. And then after delivering the blood products, we did the cleaning. After the cleaning, she had to go back to her hematologist again so that to check if she needed any extra bleeding products. And then we used tranexamic acid to make sure that the further bleeding did not occur after the procedure. So this is just for scaling. You can imagine how this patient has to deal with this issue every single day of her life. So as for the acquired bleeding disorders, so the acquired bleeding disorders can occur as a result either disease, medication, or genetic predisposition. So with the disease, patients that have liver or kidney problems, patients that have vitamin C deficiency, immune response problems such as patients that have autoimmune diseases, or cardiac failure, all are prone to bleeding. In addition to that, you have the patients that are on medication. So these medications include the antiplatelets, the anticoagulants. Some NSAIDs also cause bleeding as well. Cytotoxic agents such as chemotherapy, biologicals, and SSRIs can also contribute to that as well. As for genetic predisposition, there's also the myeloblastic syndromes, leukemias, DIC, and ITP. So all of these are conditions that you acquire. We're not born with them, but we may have them. We may develop them during our life. And so you have an increased risk of bleeding when you have them. So in this lecture, I'm mostly going to talk about the medication aspect. So with the medications, so who are the patients that are usually taking the medications? You have the cardiac patients that are on pacemakers or cardiac devices. You have patients that have had valve replacement, atrial fibrillation, myocardial infarct. You have patients that have vascular problems, those that have had stroke or cancer, leukemia, DVTs, pulmonary embolism. And also patients that have had any form of joint replacement, morbid obesity, prophylaxis, or autoimmune conditions. So talking about the medications, this is a brief, simplified way of categorizing the blood thinners. So we have the antiplatelets and the anticoagulants. So with the antiplatelets, you have the aspirin and the clopidogrel, which is the Plavix, which is what everyone uses. And then we have the anticoagulants, which are also the heparin, which are injectable. You have the direct oral anticoagulants and the warfarin. So in this topic, or in this specific lecture, I'm going to be talking about the ones that are taken orally and not the ones that are taken through injection. So patients that are taking medication, so how can you tell these patients have bleeding or are on bleeding medication or on anticoagulants? So if you notice the first picture, this is a patient who's had implants placed in their mouth. So they tend to bruise very easily. So you have to bear that in mind. The second thing is that you can have blood blisters as well. So these patients, again, they have a tendency of developing blood issues and blood blisters, petechiae inside the mouth and in the floor of the mouth. And also, if you see the last picture, this is a patient who had a large number of teeth extracted, and he also had prolonged bleeding as well. So these are general ideas of what you might see in a patients that are taking anticoagulant medication. So we'll start with the antiplatelets. With the antiplatelets, again, this is a, if you like, a diagram just to show how they work. It's a bit complex. It involves tissue factors, collagen, and von Willebrand factor. And again, you have the different types of medications acting on the pathways on different sites. So with the antiplatelet medications, we're mainly used to aspirin and the clopidogrel, which is the Plavix, although there are also new types which are reversible. However, they're not very common and they're not very much used, even here in Kuwait. So the advice for patients that are taking antiplatelets. So first of all, you have to plan the procedure. You have to know what you're doing. You can't just blindly decide what procedure you're going to do. It's better to plan it earlier in the day and earlier in the week so that in case the patient develops any blood issues or blood bleeding problems throughout the week, you can manage them earlier on. The most important thing is do not interrupt their medication. Never stop their antiplatelets, regardless of what the patient says, unless the hematologist tells you to do so. Never stop the medication. Make sure that the procedure is atraumatic. Make sure that you use local measures. Avoid using NSAIDs, because NSAIDs, again, they have a high risk of increasing the bleeding. Consider tranexamic acid as a mouthwash, again, and also provide post-operative instructions and tell them where to go in case of emergency. So as for the anticoagulants, we're all familiar with warfarin. So with warfarin, it affects vitamin K and it's reversible. There's a lab test that is usually done, which is the INR or the prothrombin time. And there's a narrow therapeutic window. So anybody can remember what's the INR in which we can work in? There's a range. What's the range? 2 or 3 is close, but between 2 and 4. Okay? So 2 and 4, this is the range in which we can work when the patient is on warfarin. The thing with warfarin is that it can interact with some food and drugs, so you have to be careful when you're prescribing the medication. Some patients may have adverse effects, and it also has a long half-life. So if you do stop warfarin, it takes about 4 days for it to be through your system. So as an alternative to warfarin, nowadays what they tend to be using is the new oral direct anticoagulants. And if you notice that they all end with "an," so we have the dabigatran, rivaroxaban, apixaban, dadoxaban, and britixiban. So all of these end with "and." So you have a patient who says that they are on anticoagulants, and they notice that they have an "and" at the end. It's the new type of anticoagulants. So with these new oral anticoagulants, they usually work on factors 2 and 10. And the good thing about them is that, again, they're taken by mouth, they're reversible, they are fast and direct acting, they're predictable, less drug interactions and food interactions, and they also have a shorter half-life. The only disadvantage with them is that they cost a lot, and usually patients are not very compliant with them. They're limited reversal agents because, as I said, some of them can be reversed. And the thing is that they cannot be monitored. So you cannot tell if the patient has a tendency to bleed for a longer period of time or not with these new medications. So patients that are on anticoagulants, before starting a procedure, again, you have to plan it. So when you plan the procedure, you have to assess the risk of bleeding of the procedure. So, for example, you can have a no risk, low risk, or high risk. So with the no risk or unlikely to cause bleeding, you have local anesthetics. So you can give local anesthetics. But when you give local anesthetics, when I mention this, you have to be gentle giving them, and they don't involve giving inferior dental blocks. They have to be infiltrations, and they have to be given in a slow manner and atraumatic manner, so you don't cause a hematoma inside the mouth. You can do the basic periodontal examination, direct restorations with the supragingival margins. You can do endodontic treatment, impressions and fittings of orthodontic appliances. So all of these procedures can be done for patients that are taking anticoagulants without the risk or without the fear of them having bleeding episodes. As for the likely to have low bleeding risk, so these are procedures that may cause low bleeding, simple extractions between 1 to 3 teeth. These are procedures that can cause bleeding, but if you exceed them, they will cause more bleeding. So you have also incision and draining of intraoral swellings, periodontal examination, the detailed one with the pocket charting, the indirect restorations which are subgingival, simple biopsies and root canal surface instrumentation. So all these procedures, okay, they cause low risk. Patients may have some bleeding in them, but that doesn't mean that they're going to end up having a prolonged long bleeding episode. So these are usually the procedures that can be done without altering the medications. And then the other procedures that cause high risk are complex extractions, which are more than 3 teeth. You have the wound closure, pre-prosthetic surgery. So all the procedures that are surgical based, these are procedures that are likely to cause a large amount of bleeding and bleeding episodes for the patients. So these you should be careful with them. So the bleeding management. So again, with the no risk, basically you don't really have to alter your management techniques. But for the patients that have low or high risk bleeding, you have to, again, plan the procedure earlier in the week. You have to make sure that you do not interrupt the medication, because if you interrupt the medication, you may have a adverse effect on their health. Some medications, like I said, for example, the apixaban and the dabigatran, they can be delayed, so they can take them later on in the day. The rivaroxaban and the edoxaban, they can be, the end ones can be delayed. The other ones can be skipped because they're taken twice a day. Again, the procedure has to be done atraumatically, and the use of gauze and sutures is very important. Do not use NSAIDs because NSAIDs, again, increase the risk of bleeding. Consider tranexamic acid and provide the post-operative instructions for the patients. So again, the local measures. When I talk about the local measures, you have to apply pressure, apply the pack, Surgicel, or any form of local measure, such as gels, can be used. And then you have the sutures. So remember, it's very important that patients pay attention to the patients that have bleeding disorders, because patients have actually died, and it's very serious. It's a serious thing. Okay, so as a summary, check your medical history, know the risk of the procedures, the local measures, and if in doubt, refer to the department in special care. These are the references. And if you have any further questions, you may contact me on the email or through Instagram. Thank you for your attention.
All right, if anyone have a question, now's your time.
Okay, then I have a question.
Yes.
If the patient have a tendency to bleeding, and still I need to give him a block, then what's your recommendation?
You should avoid it. You should use infiltration and use the intraligamentary as opposed to using a dental block, because a dental block has a higher risk of creating a hematoma, and then the management of the hematoma is a lot more difficult than the hematoma that's caused around the tooth. So avoid block at all cost.
Okay, thank you very much. It's clear. Any more question?
Yes. You're welcome.
I am an orthodontist.
Yes.
But accidentally last week I saw a patient at around 1:30 after we finished, and he done scaling, and he was bleeding excessively.
Yes.
Like when he wiped his mouth, the tissue was filled with blood.
Mhm.
It was around 1:30 in the afternoon. So
Okay.
the center was closed. He went to the emergency at Forwani Hospital, and they refused to see him. They said this is a dental problem.
Okay.
So he saw me in the street. I was just waiting to go to my car, and he just pulled from his car and he told me, my son is bleeding. What should I do? The center is closed. They refused to see me. So I went with him to the emergency. I spoke to the doctor myself, and he still refused to see him. I spoke to a different doctor anyway, and then I convinced him it's not a dental problem anymore because he's still bleeding. We cannot do anything for him. I asked his father, does he have any bleeding history or any disorder history? He said he doesn't remember. But anyway,
yes.
So they saw him at the end after I convinced the doctor to see him, and so they requested like a CBC and a coagulation profile on that. I didn't follow up with the patient, but like in the future, if this happens, what we're supposed to do?
Yes, thank you very much for this question. It's actually very important because, again, like you said, the emergency departments in the hospitals, they consider this as a dental problem, when in actual fact it's a medical problem. And so we actually had a similar case. We had a patient who came to us from private, and she had the periodontal surgery done on her gums. She had been bleeding for 3 days, and she wasn't aware why she was bleeding. So she came in, and she had a pack in her mouth, and still the site was oozing blood. So in this case, we had to take her to the hematology outpatient, not the emergency department, the hematology outpatient clinics. But this is again during the yeah. So they have to see the hematologist eventually. We have also another case who has sickle cell anemia, and we're managing her in Adan as well, and she's going through orthodontic treatment. So for her, with her hematologist, because like I said, patients with bleeding disorders, it depends on, each case is unique. So the hematologist decides what's the protocol for them. So for the sickle cell patient, she has to actually take about 5 bags of blood before she comes in to have any form of even scaling done on her before she can be referred to the orthodontist. And again, with the orthodontist, because of the problem with plaque control, she has to have the scaling done on a regular basis. So again, with these patients, if you suspect large amounts of bleeding, they have to be seen by a hematologist. We can't prescribe, we can't prescribe just the lab request and then tell them. No, they have to be seen by a hematologist. And then once they're seen by a hematologist, you have to contact them, and you have to make sure that you know what their protocol is. Because I know with orthodontic treatment, they need the regular follow-ups and checkups to make sure that they don't have any.
I mean, he wasn't an ortho patient.
Yeah. He wasn't scaling. He just wanted scaling. Yeah, that's the thing.
So I mean, for
they should apply pressure, and usually chlorhexidine, it should be tranexamic acid is better because chlorhexidine does not have any antifibrinolytic action. So tranexamic acid is much better, but again, it's not available to everyone. It has to go through the hematology outpatient. They're the only ones that can prescribe that. So again, if you have such a patient, make sure that you refer them to the hematology outpatient department, and they should have a look at them, because this is the same thing that we went through in Adan when we had that patient. We did the blood test. As it turns out, she had idiopathic thrombocytopenia, and she didn't know that she had it. She didn't know how she developed it. And so through the hematology, luckily there was someone on call that day, and she managed to see that patient. So yeah, so with this patient, make sure that they do see a hematologist. And if they do see a hematologist, I'm sure you have a special care department also in Parwania, so yes. They should learn how to manage these patients in that department as well. Okay?
Any more questions? Dr. Fatma, thank you so much
You're
for
welcome.
revisiting this very important aspect in dentistry.
Thank you.
As a general dentist, it's like sometimes we get tunnel vision on one problem and not focus, just like we're not treating just the mouth, you have to deal with like the whole body.
In a holistic way.
Exactly.
Yes.
So thank you so much.
You're
we really
welcome.
appreciate it.
Thank you.
And
Just one more thing. If anybody has, this is the textbook that everyone's been asking me about. This is the one I contributed to, a couple of chapters, and you can purchase it on the Wiley website. It's available to order. I don't get anything from this, but it's just for anyone who's interested to getting more information on management of patients. This is a very useful book, and it's similar to ones that I've seen, like the practical management to prosthetic treatment or like that. It's a simpler version of management book. Okay? Thank you.